Everyone, we are going to go. Right. Oh. What is wrong? Good morning, everyone, and welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. The Commission's strategic plan for 2020 through 2023 is committed to advancing the Commission's vision of well-being for all Californians. Let's bring up the strategic goal slide. Thank you, Cody. Now we will take the roll and establish a quorum. Jeff, can you please take the roll?
Absolutely. Commissioner Bontrager. Commissioner Brown.
Here.
Commissioner Bunch. Commissioner Carnevale.
Here.
Commissioner Carrillo. Commissioner Chambers.
Present.
Commissioner Chen.
Present.
Commissioner Cortese. Commissioner Danovich.
Here.
Commissioner Gordon.
Here.
Commissioner Mitchell. Commissioner Robinson.
Present.
Commissioner Rolette.
Here.
Commissioner Tamplin.
Here.
Vice Chair Alvarez.
Here.
Chair Madrigal Weiss.
Here.
Madam Chair, you have a quorum.
Thank you, Jeff. We are now moving on to Agenda Item 2, Announcements and Updates. At this time, I would like to make a few announcements. The June 2023 Commission meeting recording is now available on our website. The next Commission meeting will take place on August 24th here in Sacramento. And at this point, we will hear updates from our committees. I would like to invite Vice Chair Alvarez and Commissioner Tamplin to provide their committee updates. If we could begin with Vice Chair Alvarez, please.
Thank you, Chair Madrigal Weiss. Good morning, everybody. It's great to be with you all, even if virtually. I'm excited to share that the CLCC met last month on June 27th and had a conversation regarding two items. One is the ongoing 2024 to 2027 strategic planning opportunity that the Commission has in front of them. And the second item was the proposed Mental Health Services Act modernization proposal. With all of the changes that we are seeing and that are coming our way, I just wanted to start with appreciation for this group of knowledgeable and passionate people that are helping guide us through this process. So just huge appreciation to our CLCC members. During that discussion, the members expressed interest in thinking through how the goals of that strategic planning process should first and foremost be aligned with the committee, and in particular, make clear through this process, what does a robust feedback loop between the CLCC and the Commission look like, particularly for priority projects? For folks that have been engaged in the Commission's work throughout its history, the role of committees has evolved, and this strategic planning process really opens the opportunity to discuss what does it look like to have an engaged committee, and how do we offer that opportunity moving forward? Additionally, the committee really thought about how the CLCC really is that avenue for marginalized communities and communities of color to bring this unified voice to the commission's decision-making process. So huge thanks to the staff of the OAC who took notes and who will work together to incorporate that into the strategic planning process. And then we also discussed the governor's proposal to modernize the Mental Health Services Act, thanks to OAC staff as well. Committee members asked questions about the current language. They tapped into their own expertise working on state legislation. We heard some concerns around prevention and early intervention. We heard concerns about specific populations such as children and youth. So it was a robust discussion that echoed much of the conversation from previous OAC meetings, but also spoke specifically to the unique needs of communities of color and other marginalized populations like LGBTQ. I think as much as there is uncertainty or anxiety associated with what is coming with regard to the modernization proposal, I think we are all confident that the discussions that we have with our community partners, with experts, with people with lived experience, that it's those conversations that ensure we're taking the best approach moving forward. So again, just want to sincerely thank the CLCC members for engaging in that conversation and for continuing to be part of these discussions in order to improve what moves forward. Finally, I just want to, again, thank the CLCC members for their patience and flexibility with the committee structure. It was the first time we were meeting in this year, and there was some questions about membership, and they really rolled with the punches. And I just want to express and acknowledge that flexibility and thank them for their continued commitment in working with us. Thank you.
Thank you, Vice Chair Alvarez. Commissioner Tamplin, please.
Thank you, Chair Madrigal-Weiss. The Commissioner, Vice Chair, Commissioner Chambers and I hosted the CFLC meeting last month on June 14th, where we focused on the MHS-OAC strategic plan and CFLC goals, the modernization of Mental Health Services Act, and care court updates. And I would like to give a special thank you to all our presenters who provided these updates and shared their ideas and perspectives. Commissioner Chambers and I, we hope that that the committee members and other members of the public can participate in the coming months in the planning process for the Commission's new three-year strategic plan to help the Commission determine the most effective ways to hear input from community partners. We heard a report out on the MHSA modernization proposal from Kendra Zoller, the Commission's legislative director, who updated the committee on the governor's proposal to modernize the MHSA. There have been some significant changes to the proposal since our meeting, so I'm interested in our discussion later today. Also, several concerns were shared, including how MHSA could and should be used to reduce the number of people who are unhoused and living with mental health challenges and or substance use challenges. And Melissa Martin-Mollard, the Commission's Chief of Research and Evaluation, provided a presentation of the challenges, opportunities, and community engagement process of the Commission's FSP project. And our discussion emphasized the importance of subject matter experts in peer services, community connections, and social supports such as self-help support groups to help sustain individuals outside of the FSP's programs. And lastly, the CFLC has provided a platform for discussion on the care courts program. And my hope is that the CFLC can continue to invite our community into discussions to enhance the level of engagement with our partners around this issue. People express that the community engagement process has not adequately included or addressed the concerns of those who will be affected the most by the care court legislation. And this includes communities of color who may have had very negative experiences in the court systems and may be impacted the most by the law. So our goal for future meetings will be to continue to provide updates and the perspective from those with lived experience and family members on the Commission's strategic plan and to ensure that the committee's future work is aligned with the Commission's objectives. And I'd like to thank all the participants who shared with us and look forward to providing updates as we make progress on the work that we do on the CFLC. Thank you.
Thank you, Commissioner Templin. The Commission has been working in collaboration with the Department of Healthcare Services on the Children and Youth Behavioral Health Initiative, a $4.7 billion investment in the mental health of our most vulnerable children and youth. A portion of the funding, $429 million, is dedicated to scaling evidence-based practices and community-defined evidence practices that are based on a robust evidence for effectiveness, impact on racial equity, and long-term sustainability. The Commission has entered into an interagency agreement with DHCS to administer grant rounds 4 and 5. Commission staff have been working with DHCS staff to create the request for application for round 4, which focuses specifically on youth-driven programs. This RFA is set to be released in the coming days. Vice Chair Alvarez was designated by the full Commission to shepherd this process. Vice Chair Alvarez, would you please say a few words about the initiative at this time?
Thank you, Chair Madrigal-Weiss. I'm so excited to announce that the Commission is going to release round 4 of the Children and Youth Behavioral Health Initiative grants, which, as you said, will support youth-driven programs that are evidence-based or are community-defined evidence practices. There's about $50 million available to scale programs that are youth-driven, that have evidence for success, and that there is hope to be sustaining those programs into the future. I want to specifically acknowledge the strong collaboration with the Department of Healthcare Services throughout this process. The Commission recently entered into an interagency agreement with the Department of Healthcare Services and has been working with Autumn Boylan and her team on this round 4. That team has provided feedback to the RFA. The Commission has responded to that feedback, and it's just truly been an opportunity to work closely together around our shared goals for ensuring that more youth-driven programs are available in our communities. Applicants may apply to support the availability of youth-driven programs, but also to open new programs, such as new alcove drop-in centers, or expand existing programs. In addition to working with DHCS, this RFA really reflects the input from our community members, specifically our young people, around the importance of having safe places to seek help and find leadership opportunities for young people. As we have said time and time again and have included in various reports, our youth should be at the table when these programs are created. And I'm confident that through this RFA, programs serving youth from diverse backgrounds, and in particular, those that are most marginalized and experiencing inequities, will be supported. Just a little bit of logistics. Each of the 6 rounds of funding does have an equity focus. The 6 rounds of the CYBHI. For round 4, it specifically calls for programs that reduce health disparities by improving equitable access to services for parents, caregivers, and children in California that are culturally and linguistically responsive to the needs of the populations of focus. So again, that is a topic of conversation and a commitment to building that expertise that the Commission has had for years. And I just want to really commend the leadership of Tom and the entire team working on this RFA to get us to a place to release it. Again, expressing deep appreciation for the partnership, the spirit of collaboration with the department and our stakeholders, and looking forward to the Commission's role in administering these rounds 4 and 5 of the CYBHI.
Thank you, Commissioner Alvarez. This is very exciting, and we look forward to learning more. And I want to thank you for shepherding the process, for stepping up when we really needed and sought out your support on this, and expanding youth programs and the equity focus, really exciting stuff. So thank you for that. And Tom and team appreciate everything you're doing in this area. So thank you. Starting next week, the Commission will hold 6 virtual listening sessions to gather input from community members on the most pressing mental health needs of 6 underserved populations in California. The purpose of these listening sessions is to inform the next round of advocacy requests for proposals. The commission will hear a presentation on the findings of this public outreach and consider approving the release of RFPs at the September commission meeting. One listening session will be held for each population, and they will be held in the evening via Zoom. Please visit our website to view the meeting details and links to join for each of the 6 populations. You can find them under Connect with Us, then All Events. At this time, I would like to invite Melissa Martin-Mollard, our Chief of Research and Evaluation, to make a few staffing updates.
Thank you so much. I am very pleased to announce that the recruitment for our 3 research scientist supervisors has concluded, and 2 current commission staff members, Kaylee Patterson and Kai LeMaison, have been promoted into supervisor roles. Kaylee will be overseeing the policy projects team, and Kai will be overseeing the Mental Health Student Services Act evaluation. Additionally, Callie Clark, currently an embedded contract staff on the research and evaluation team, has been offered the supervisor position that will oversee the full service partnership project. Congratulations, Callie, Kai, and Kaylee. We look forward to your continued support on these important projects within the research and evaluation team. And if they're in the room, I think Callie is out, but Kaylee and Kai, if you want to stand and just say hi, that would be great. Thank you.
Congratulations, ladies. Cynthia Burt. I would like to announce that one of our most knowledgeable staff about all things MHSA is officially retiring. Cynthia Burt has been involved in behavioral health for decades and has brought her expertise and heart to the work every day that she has been with us. Her expert knowledge on the history, regulations, background of MHSA has served us well in our work and in our communications with counties. Please join me in celebrating her much-deserved re-retirement. We wish her the best. Is Cynthia here? Okay, Cynthia, are you online? So we just want to say congratulations, Cynthia. I understand it's a re-retirement, so we'll see if it sticks this time. But we just want to say congratulations to you.
Thank you. It took me a minute to find my place in the line. I appreciate very much the words, the kind words, and the OAC was always my kind of sanctuary after I left DMH, and working with the program operations team and Charmel was just heaven. I can't think of a better way to end a career. Thank you so much.
Thank you. Again, congratulations. And now it is with a heavy heart that I announce that Charmel Shaw, our Chief of Program Operations and Lead of Innovation, will be leaving the commission. Charmel, do you want to stand? She has accepted a position as the Assistant Deputy Director in the Office of Health Workforce Development at the California State Department of Health Access and Information, HCAI. Let's go with that. In this role, she will oversee the work of 65 professional staff in the areas of operations, health policy development, research and evaluation, and grants management. This is a great loss for the commission, and we appreciate all her valuable contributions over the past 7 years, especially in innovation, where she was instrumental in a statewide culture shift related to the county's use of innovation funds for transformational change, pivotal in maintaining and fostering significant county relationships, and the creation of the Innovation Incubator. Please join me in celebrating her new executive leadership position and wish her the best of luck always. So let's welcome her. And if there are any commissioners that would like to say a few words to Charmel, then please
Madam Chair, I'd like to say a few words. Just, Charmel, thank you for always, being there for us when we needed you, answering questions about innovation projects and everything that you've done. It's been with your, integrity to the mission and values of MHSA and also bringing us the information that we needed to do our roles effectively and just being a friend and wonderful person to work with and collaborate with. You've always been welcoming and supportive to me, and I look forward to the continued relationship in your new role. Excited for you, sad for us, of course, but I know that the work at HCI is going to really enhance also the recovery vision that California really needs to achieve and still strives for. So we're very lucky that you're going to be supporting the workforce and helping us achieve more of the goals we have around training in that area. So we're lucky in that way too, but still sad because, I hope you still can show up in these meetings. And of course, we'll always get together because you're a wonderful person and they're very lucky to have you.
Commissioner Danovich, please.
Yeah, I would just echo Commissioner Templin's comments. Charmel, it's been an absolute pleasure to work with you. In addition to all your hard work and intelligence and diligence, you do your work with so much dignity and professionalism. And you really are a model for, a sort of continued growth mindset and orientation. So it makes it a pleasure to work with you. I think you've elevated all the projects that you've been a part of. It's been inspiring to see you grow and excited for you with this next opportunity.
Commissioner Alvarez.
Thank you, Chair Madrigal-Weiss. And I also just want to echo my fellow colleagues' comments and +1 to everything that Commissioner Danovich and Commissioner Templin had said, and express my deep appreciation for Charmel and everything that she has done to support my own learning journey, my awareness of how the commission operates, and also the way she's been able to use her patience, her commitment to connection, her value of relationship building to really move things along in a way that is incredibly strategic, but in the most positive way for our most marginalized communities. I will truly miss seeing you and feeling welcomed by you at these meetings. And HCI is incredibly fortunate to have your expertise with them. There's a lot of exciting things happening at HCI, particularly related to our workforce and who we value as members of our workforce. And to know that your heart, and again, your commitment to connection, your commitment to relationship building will be influencing those processes means that the future health workforce for California is going to be stronger and more community oriented because of what you're bringing. We will miss you deeply, but wish you the most success at HCI, not only for you and your own growth and opportunities, but for all of us in the state of California. So huge thanks, Charmel.
Thank you. Please, Commissioner Brown.
Sorry about that. I just want to add that in addition to being such a great professional and amazing researcher and presenter, Charmel is also one of those special people that just kind of lifts you up every time you see her. And that $1 million smile of hers will be greatly missed. And she is just got so much grace and an amazing personality that just makes people feel welcome. And it's remarkable because the staff here is incredibly reflective of that, but she's just an amazing person that stands out. And so we certainly will miss you. And I'm sure Toby was trying to figure out a way to sabotage this plan at some point, but we wish you the best. But you've left a wonderful impression here on all of us and all of the people that we serve. So thank you, God bless you, and Godspeed.
I'd like to say, I think all the adjectives of just how wonderful you are, Charmel. I think of you and I think of integrity and grace from day one. You have been just so receptive, so helpful. I can reach out to you really early morning, real late night, and you shouldn't answer some of those calls, but I appreciate when you do because they're good questions. But just the care and commitment you have to our communities, our counties, youth and all peoples, and the seriousness that you take your role, it's just made a world of difference. So in the time that I've been here, you've been here, I think we've been here the same amount of time. It's been an incredible journey, and I trust in your leadership that things won't skip a beat because you work with a brilliant team and they will continue on. So thank you for all you've done for us. Really appreciate it and wish you the best. And we'll still stay in contact, so all good. So, thank you so much. Again, congratulations. Please. Okay, thank you.
I actually wasn't planning on saying anything, but I'm really overwhelmed by all of the comments and observations and support. And it has been an amazing journey working here at the commission and with all of you, especially in this role of co-leading with Tom the commission meeting. I've had this wonderful opportunity to get to know each of you and the amazing work that you do, each of you do in your own areas. And I've learned so much from all of that. So I just want to thank all of you again for helping me grow and teaching me things that I never would have learned if I hadn't been here. And so I just want to thank each of you for all the learning and all the love and all the support. And it's only going to help me in my future endeavors. So thank you again. Thank you.
All right. I want to welcome everyone again to today's meeting. The plan is to end at about 3:10, 3:15. Commissioners, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the commission staff can make you a co-host again. If you have a comment to provide, please unmute your line and seek recognition when it is convenient. It is now time for agenda item number 3, general public comment. This is time reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Lester to go over public comment procedures.
Thank you, Madam Chair. All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we will be able to hear you. We will do our best to take comments in the order that they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment before discussion on the agenda item, before the agenda item ends. The moderator will insert the word last comment next to the commenter's name or phone number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on the time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We appreciate your understanding in this process. Lastly, if there are any members of the public using translation technology, please notify the chair, and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is currently not visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. Madam Chair, I turn it back to you.
Thank you, Lester. Would you please open the line for general public comment?
Madam Chair, there are no comments in the room, and we have 2 online.
Please go ahead.
Stacy, your line is open. You may go ahead.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. First, I would also like to congratulate Charmel. She, as people have spoken so highly of her, deserves every word. And I'm so happy she's going to HCI because all the people I know at HCI are really very, very friendly and professional and helpful. So I hope, Charmel, that you have a really good experience there as you have with the commission. I wasn't going to speak, but I did want to thank the commission for having the listening sessions in regards to the stakeholder advocacy grants, which will be coming up. I didn't realize that the RFP was coming out so soon in September. I hope that the commission will consider letting part of that RFP pay for state level advocacy, or at least a greater part. I think with the governor's proposal, it is obvious that there are some state level mental health and behavioral health issues that really need to be dealt with at the state level, of course, as well as at the grassroots. But when these grants were originally handled by DMH, Department of Mental Health, they were primarily at the state level. And I have missed my colleagues, but they are often unable because they are so busy, fulfilling the other parts of the contract that they cannot do state advocacy because it's not often paid for. So please consider putting more funding or requirements of those grants for state level advocacy. Thank you.
Thank you, Stacy.
Andrea, your line is open. You may go ahead.
Hello, good morning, everyone. I just too wanted to say, what the heck? First Brian and now Charmel. What a loss. Charmel, I just want to just congratulate you on your new role and thank you for all of the hard work that you did to lift the Mental Health Services Act up, especially innovation. And additionally, I just want to say that I concur with Commissioner, I believe it was Danovich, that said you just really modeled professionalism and dignity. And I know that when working in these roles, especially such public facing roles, it's hard. So just really appreciate you. And I'm really excited that you'll be moving over to HCI. And just one little request is that I hope that you take forward all the great work the OAC does with incorporating the public voice, the community planning process to HCI. I think that that's something that I hope continues to be modeled throughout the state and grows and ensures that we have the voices of those individuals that are directly impacted by these decisions at the table. But I wish you the best of luck, and I look forward to the conversation moving forward on SB 326. Thank you.
Thank you, Andrea.
Hector, your line is open. You may go ahead.
Good morning, Commissioners. My name is Hector Ramirez. I'm a consumer at the Los Angeles County Department of Mental Health in Los Angeles County, which serves over 250,000 residents here in Los Angeles County, many of which receive mental health services, funded services. I want to thank Stacey Hiramoto for her comment. That was one of the things that I was here to speak about. As a consumer, doing advocacy work is something that we do here in Los Angeles County as stakeholders out of our pocket, because there's no state-funded or county-funded consumer advocacy program. We as consumers here in Los Angeles County are dealing primarily with revamping the mental health services and not having to end up in jail or homeless out in the streets like the majority of the people experiencing mental health here in Los Angeles County crisis. And we as consumers have had to, and are currently still doing, we recycle cans, we donate blood and sell it, we have food drives, so that can we participate both not only in mental health stakeholder activities at the county level, but also at the state level, since there's currently no advocacy program that funds stakeholder involvement regarding Mental Health Services Act at the state level. And that is one of the things that I really would like to request as a representative of the Los Angeles County Department of Mental Health, given the fact that we play such a significant role, not only in state policies, but in the great work that we have done along the Mental Health Services Act. I'm sorry, there was somebody speaking. I'm sorry, is there somebody else speaking? Okay, so thank you. Definitely, I want to make that request, given the fact that Los Angeles County not only has the largest resident population in the state of California, but we have one of the most largest intersectional population with our Latino, our Native American, our African American, and our API communities. Thank you.
Thank you, Hector.
Tanya, your line is open. You may go ahead.
Good morning. Thank you for having me speak. My name is Tanya Savis, and I'm Director of Veteran Advocacy for the Veterans Art Project. And we're coming to the end of our 3-year innovative project that you have funded for us. And I want to say thank you. As someone with lived experience as a veteran, I see the importance of these pop-ups and how it has helped engage the veteran back with the community. Just the overwhelming support that the veterans are getting from the community when we go to these locations to do the pop-ups are overwhelming. They're at shock and surprised that an organization will care about what they do as a veteran and getting them reconnected to their ecosystem. So again, I want to say thank you. And as we come to the end of our 3-year project, we're going to be in Sacramento again on October the 17th. And we would definitely love to have you come and see the art by the veterans and hear the stories behind the art. Once again, thank you, Masaka.
Thank you, Tanya.
All right, we have one more public comment. Jerry, you may go ahead.
All right, great. Thank you very much, Chair White and commissioners and staff and guests. I speak today to continue to urge the MHSOAC and the future BHSOAC to help counties understand key elements of existing code, providing advisory boards their utmost best to methodically and meaningfully engage consumers, families, and all stakeholders to authentically participate in the community program planning process. In most of the behavioral health meetings, committees, work groups, and councils I attend, and in most of the analyses, reports, and plans I read, we talk about community engagement and the importance of it and the importance of this, the community program planning process. The good news is that there's a legislated, codified, and funded mechanism already in place to facilitate this work. And even so, I'll bet most people here think that we're doing a great job with community engagement and that there really isn't much need for improvement. I would argue that senior leadership in many counties I know of do have community program planning process, work groups, forums, and end up generating reports. But typically the plan for the CPP is something that is not given to the advisory board for review and approval. And my concern is that we have more opportunities to engage the advisory boards more meaningfully and to get their review and approval of the plan so that they can ensure that the communities are engaged on an annual basis. Thank you.
Thank you, Jerry.
Chair, that was our last public comment.
Thank you, Lester. The commission will now move on to agenda item 4 and consider approval of the minutes from the May 25th, and June 15th, 2023 commission meetings. At this time, I would like to invite commissioners to offer comments or ask questions. Seeing none, I will ask that for members of the public may request to make a public comment on agenda item 4 by clicking the raise hand button on your computer or the app, or if calling in by phone, please push *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, please limit your comments to 3 minutes or less. Lester, are there any public comments? Please raise your hand now as the queue will be closing. Lester, please open the line for public comment on the agenda item 4, and we can start with the comments from the room if we have them.
Chair, there are no public comments.
Okay. And online?
No public comments online or in the room.
Thank you. So, no questions or comments from any commissioners? Then I would entertain a motion for the May commission meeting minutes.
So moved.
Thank you, Commissioner Brown, and second, Commissioner
Yes, I'll
Tamplin.
second. Thank you.
Thank you. Jeff, can we take roll, please?
Gladly. Madam Chair, before taking the roll, I would like the record to reflect that Commissioner Bontrager has joined the meeting at this time. For the minutes, Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch. Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette.
Aye.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff.
Minutes.
Thank you. Now for June, the meeting minutes for June, are there any questions or comments from commissioners? Seeing none. Do we have public comment for the meeting minutes in June?
Madam Chair, there are no public comments in the room or online.
Thank you. Can I have a motion for the June meeting minutes?
So moved.
Thank you, Commissioner Robinson. Do I have a second?
Second.
Thank you, Commissioner Carnavale. Jeff, could you please take roll?
Indeed. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch. Commissioner Carnavale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Chen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Abstain.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette.
Aye.
Commissioner Tamplin.
Aye.
Vice Chair Alvarez.
Abstain.
Chair Madrigal Weiss.
Aye.
Madam Chair, the motion to approve the minutes passes.
Thank you, Jeff. We will now move on to agenda item 5, the item calendared for consent. This includes the approval of an innovation project from Santa Clara County, Commission staff have sent the documents related to these projects to all commissioners at the time the July agenda was posted, and a copy of the staff analysis for Santa Clara County has been provided in your packet. These projects had a significant amount of community engagement, not only at the local level, but also through the commission's process, which is outlined in the document in your packets. The county has also received over 40 letters of support. As a reminder, any commissioner can remove an item on the consent calendar. That item would then be considered as a regularly scheduled agenda item. At this time, I would like to invite commissioners to offer questions or ask questions. I see none here in the room and none online. So I would ask that we can have members of the public may request to make a public comment on agenda item 5 by clicking the raise hand button on your computer or the app, or if calling in by phone, push star 9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Also, please limit your comments to 3 minutes or less. Are there any public comments? Please raise your hand now as the queue will be closing. Lester, please open the line for a public comment on agenda item 5, and we'll start with any comments in the room.
Chair, there are no comments in the room. We have one public comment online.
Please go ahead.
Hector, your line is open. Please go ahead.
Thank you. Good morning. So I really want to thank the commission for looking at this particular item. And I really would like to request that just with every other projects that there be an articulated emphasis to ensure that all projects that are funded by the commission and approved both provide the required disability accommodations for the community to be able to participate in the services, as well as the linguistic accessibility service provided, so that individuals that have specific linguistic access be able to access all of the same Mental Health Services Act funded services that are going to be provided regardless of the formula. And with this, I would also like to make a technical request that as you're making these allotments, that you incorporate into the funding formula an opportunity to include money to provide accessible services for people with disabilities and linguistic services, in addition to what the counties are asking in their budgets, since it's oftentimes not reflected in the current cost or need that they might need to provide. And that can result in people not getting access to the services. Thank you.
Thank you, Hector.
Madam Chair, there are no more public comments.
Thank you, Lester. Now that public comment has closed, I would entertain a motion that the commission approves funding for Santa Clara's TGE Center Innovation Project.
So moved.
Thank you, Commissioner Gordon. Do I have a second?
Second.
I second.
Thank you, Commissioner Templin. We have a motion and a second to approve the consent calendar. Are there any additional questions or comments from commissioners? Seeing none online or in the room, I would ask that Jeff please take roll.
Commissioner Bontrager,
Aye.
Commissioner Brown,
Aye.
Commissioner Bunch, Commissioner Carnavale, Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen, Commissioner Cortese, Commissioner Danovich,
Aye.
Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Rolette,
Aye.
Commissioner Tamplin,
Aye.
Vice Chair Alvarez,
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff. Congratulations, Santa Clara County. We hope to hear back. Sounds like a very excellent innovation project. I've read through it and really looking forward to hearing back, so we hope we get to do that. At this time, we are going to take a 6-minute break. We are ahead of schedule, so let's stretch. We'll come back at 10 a.m. Thank you so much, everyone.
Yeah, I was like, what?
All right, we are back. We will now move on to Agenda Item 6, the Mental Health Services Act Modernization Proposal. At our April Commission meeting, the California Health and Human Services Agency and Department of Healthcare Services presented Governor Newsom's proposal to modernize California's behavioral health system. Since then, the proposal language was released through Senate Bill 326 by Senator Eggman on July 13th, and the housing bond language was released on June 19th through Assembly Bill 531 by Assembly Member Irwin. Today, we will hear an update on the proposal and status of the pending legislation from California Health and Human Services Agency and the Department of Healthcare Services, followed by a panel discussion with key partners to help identify opportunities, challenges, concerns, and potential solutions in relation to the proposal. First, we will hear a presentation from Stephanie Welch, Deputy Secretary of Behavioral Health and the Health and Human Services Agency, and J.C. Cooper, Chief Deputy Director and State Medicaid Director at the Department of Healthcare Services. Welcome, Stephanie and J.C. Please go ahead.
Hi, everyone. Good morning. Thank you for asking agency and DHCS to come back to provide an update today. My comments today will really focus on grounding us in the objectives of what we were trying to accomplish with the proposal and to highlight some of the modifications that have been made. I'm going to do my best to also answer any questions. I'm very glad that I'm here with my colleague, Chief Deputy of DHCS, J.C. Cooper, and also our State Medicaid Director, to answer questions, and I think most importantly, to listen. I think that's really what we've been doing a lot of in the last, I guess it's been about 2 or 3 months since we've been here. It's been an incredible opportunity to listen and learn, acknowledging several concerns, acknowledging several creative ideas on how to make the proposal better. And so just to really appreciate for those of you who are either on the panel or commissioners that we've had an opportunity to talk to, I hope that you see this as the beginning of ongoing conversations. I think in conversations with the secretary that I have been talking to, is that this particular process, and in particular working on this particular proposal, has brought us the opportunity to learn more about the work that you do. I've had an opportunity to go back and look at the grants that you guys have administered, and it really has been an eye-opening experience to learn more about the work that you do. So I want to acknowledge that that's some of the work that we've been doing, and to better understand how we can use this as a unique opportunity to make sure that there's a more collaborative relationship between the administration, oh, hi, Jolie, the administration and the commission. So I think one of the questions you posed to us, whether it was last time or in your letter, was very specifically, why are we doing this? Very specifically, why are we doing this? And I just wanted to point out a few things. I'm sure that you guys have spent a lot of time reading a lot of the materials, which is why we didn't come here today with a bunch of slides. Really want to just give you some verbal updates and have a dialogue. But I think if you look at in SB 326 intent section, there's probably about 2 pages of statistics. And I think they're really jarring. For example, the rate of substance use disorders amongst youth 18 to 25 is nearly twice that of adults and 3 times that of adolescents. We have Latinx, Asian, and Pacific Islander Medi-Cal enrollees not accessing services in both managed care plans as well as county specialty plans. We have an extensive growing demand and need for infrastructure. And that's not just capital infrastructure for facilities or for housing, it's really for our workforce. We have 1 in 3 individuals who are incarcerated in our state who are diagnosed with a serious mental illness. And our point in time count, until a more recent study by UCSF, we always just thought it was about 1/3 of our unhoused population was living with a serious mental illness. And what we found in the more recent study that was incredibly in depth is that that over 65% of individuals were experiencing symptoms of depression, anxiety, trouble concentrating or remembering, or hallucinations in the last 30 days. So just incredible need in our community. It doesn't mean that there wasn't an incredible need 20 years ago when people came together to draft the Mental Health Services Act, but it does recognize that some of the needs are different. I think even in our conversations, whether it be broadly with stakeholders or with all of you, I think there's an acknowledgement that a fine-tuning of the MHSA is appropriate 20 years later. First and foremost, want to acknowledge that the MHSA was drafted before mental health services were really a part of our everyday healthcare system, both in our commercial and Medi-Cal plans. Before the major reforms literally were built into the core of our healthcare delivery system. There was no Affordable Care Act. There was no strong California mental health parity protections. And this administration in the last several years has invested over $10 billion into the overarching behavioral health care continuum. And I think one of the things that I think about in doing this work is the medical model that is our Medi-Cal system is a system of yesterday. We're really trying to focus on making Medi-Cal the system of today and tomorrow, which means that it has to be designed in a way that addresses the social drivers of health. Leveraging our Medi-Cal system means that we can bring in more federal dollars into our state. It means that certain services will now become obligated services that our county specialty system has to provide, as well as our managed care plans. And collectively, over time, it means that we're going to have more resources for the kinds of services that the Mental Health Services Act pioneered 20 years ago. And I think that, I hope that you hear today that that was really part of what our intent was. We want to bring more resources into our system so that we can expand care. So I wanted to give a little bit of an update of some of the specific changes that you hopefully saw in the actual legislative language since April. So first and foremost, the bond. I think when I came here last time, we weren't really sure where we were going to land in terms of the dollar amount. We do know that it's around $4.7 billion that we are proposing. That is encapsulated in AB 531. That is the bill vehicle for the bond. We intend to build 6,000 new unlocked community behavioral health beds in residential settings for Californians who have mental health challenges and substance use disorders. We also intend and aim to build 1,800 permanent supportive housing units for people experiencing homelessness who have behavioral health conditions, and another 1,800, I'm sorry, I said 18,000. Wow, that would be fantastic, but we don't have that much money. 1,800 for both housing units for veterans with behavioral health conditions. I'm not sure if we knew this when we were here last time, but we are aiming to be on the March ballot of 2024. We heard loud and clear, not just from you, but for, I would say, people across the lifespan that are thinking around prevention and early intervention being a part of the behavioral health services bucket was poor thinking. I think that we heard a lot of incredibly excellent arguments, and as a result, we have proposed in the in the legislation for keeping the 20% of the prevention and early intervention, with 5% being set aside specifically for population-based prevention, and the majority of the 30% of the behavioral health services and supports component going towards early intervention. We really looked at some of the pioneering work that this particular commission led in this space, and felt that this was an important piece to keep, and I think that the dedication of the 15% to early intervention is notable. And I hope that folks have taken a look at the language of what we think are the kinds of services that should be funded with early intervention, component. I guess it's not a component, but element. And next, really, that I don't think I had an opportunity to give an update on when I was here last is really this kind of dedicated, ongoing ability to invest in workforce. We may have alluded to it, I can't remember, but we've identified being able to utilize up to 3% of the MHSA funds, now BHSA funds, for a statewide investment in the behavioral health workforce. In the beginning of this process, we are going to use some initial dollars, and JC might be able to speak to this more clearly, but use some initial dollars as part of our BH Connect, or our waiver, our 1115 waiver demonstration that we're submitting to CMS later this year, to draw down $480 million annually for a 5-year, for a total of $2.4 billion for a 5-year demonstration period. This does require federal approval, but this is going to allow us in the long term to really sustain investments in the workforce, and probably more importantly, to create a workforce of tomorrow, to create a much more substantial SUD workforce, but also to think about training. How do we bring in new people and new systems into this work? I think another thing that I know that this group will be very interested in, we'll probably have lots of dialogue about, is that we define in statute full service partnerships. This is near and dear, I think, to many of our hearts in trying to move from originally AB 34 to 2034 to full service partnerships of today and tomorrow. And so 35% of the MHSA would be directed towards funding full service partnerships. And counties will not be able to report their federal financial participation as part of meeting this 35%. It will only be for, I'm going to start calling it the BHSA expenditures. We define full service partnerships to include an array, or I would say kind of levels of care, all the way from a very, very high level of care like an ACT model, assertive community treatment, or forensic assertive community treatment, to lower levels. And we identify, and I think this is really important because this is really an area where we need to collaborate not only with the commission, but also with providers in the field who have pioneered this space. So very specifically, FSPs will have an established standard of care with levels that are based on an individual's acuity and criteria for step down to an FSP level that provides the greatest degree of independence and self-determination. We look forward to working with all of you as you have been doing a lot to learn in this space on this topic. Lastly, we have reframed the concept of innovation. I know we spoke a lot about, I think that was probably the primary thing that we really spoke about last time we were here, and in other conversations we've been able to have with Toby and with commissioners who are really passionate about this topic. It is our intent to continue to foster ingenuity and to swiftly create responsive services and supports so that we are leading and that we are learning and leading towards improved outcomes. But we do think that having a set-aside component has been difficult for the counties to utilize that funding in a swift way. We want to preserve the intent of the innovation component without administrative obstacles. Counties will have the flexibility to test and pilot behavioral health innovative models of care and promising practices across all of the Behavioral Health Services Act buckets. And the goal of these innovation pilots and promising practices would be to build the evidence for the effectiveness of those new statewide strategies so that we can advocate for those to become statewide strategies, even potentially strategies that we could advocate to CMS to be inclusive in our Medicaid program. So those are what I think are probably the big things that are different, that were changed. And I guess what I would say before I pass it over to JC, I think will kind of come back to me for a second, but you asked a lot of questions around process. I'd have to say that in full transparency, we can't talk today about amendments. This is a joint proposal between the administration and the legislature. But I do want to say that we're here and here to listen and learn, and that we are obviously going through the legislative process. To be really frank, there's going to be amendments. There's going to be more changes. There could be several more changes. It will be a quick process. The legislature is in recess right now. They come back August 14th, and I do think that it will be a very busy time between August 14th and September 14th. So thank you, and I'm going to pass it over to JC to give a few updates.
Good morning, everyone. JC Cooper, State Medicaid Director, and happy to be here with you today. I'm going to be walking through, there's been some questions that we received from the commission in regards to DHCS's experience with implementing large-scale policy changes. So I'll do a quick overview on some of those pieces. I'll try to focus on the intersection with behavioral health. I'll also walk through some of the various oversight and accountability pieces within the Behavioral Health Reform Initiative, just because I think they're very critical for us to ground ourselves. A lot of the conversations have been focused on the categories and other pieces, but there's a lot in here around data transparency and accountability that we think are very valuable to this proposal, and just want to make sure we do an overview and answer any of your questions around that, and then how we can maximize Medi-Cal, as Stephanie outlined in this proposal, and for behavioral health services across the state. So DHCS's role in policymaking and oversight across the state, we serve as the single state Medicaid agency, but we also serve as the single state agency for substance use, as well as mental health authority within the federal government eyes and across the state of California. We work with all 58 counties around behavioral health services across the state. We also issue billions of dollars of SAMHSA block grant dollars to both counties and providers across the state every single year. So we have a large experience in regards to working with our county partners, writing, delivering policy, and getting dollars out the door from both the federal and state to our local counties and providers to provide the critical services that are needed on the ground. We also serve, at this point, over 16 million people in Medi-Cal in the state of California. We used to say 1/3. We are far above that now. So we are touching a significant portion of lives across the state of California. We're also used to leading complex policies. That is not foreign to us. We were the first in the nation to put forward an SUD proposal to draw down federal funds for IMD services and to fully change our substance use disorder services across the entire state of California, breeding a constructed delivery system, increasing the amount of benefits and services, and California led, and the Department of Healthcare Services led that initiative, which now has been brought up by many other states behind us. We were also the first in the nation to approach the federal government to say it is not just around medical services or behavioral health services. There are other services and supports that are needed within the Medicaid program to support our individuals to be successful, to improve their health outcomes. And we were the first in the nation to have a full set of 14 community supports approved, things like housing services and supports, transition services, respite services, including behavioral health, respite and community recuperative care services, sobering centers, drawing down federal funds for those services across the entire state of California. Since launching, we have seen a significant increase of those providers across the state. We also are the first in the nation to get an approval from the federal government to do a justice-involved initiative. Well, we will be providing physical and behavioral health services for 90 days in every prison, jail, and juvenile facility across the entire state of California with Medicaid dollars to ensure that individuals, while incarcerated, are getting the needed services that they need. We also negotiated legislation at the state of California mandating a warm handoff with our behavioral health counties and providers to ensure that there is a warm handoff into the community, because we know, based on a 5-year pilot that we did in California in 17 counties, that it has a profound impact on reducing suicide rates, recidivism, connection to SUD and behavioral health services upon reentry into the community. And we are getting ready to launch that. We are going through readiness process in the state of California with the first counties that elect to go live in April of 2024. We also have expanded Medi-Cal to all eligible individuals in California, regardless of immigration status, because in California and in Medi-Cal in particular, and with this governor in particular, doubling down and making sure all Californians have access to critical services. I say that we do these things, but we also try to do them in partnership with our counties and providers. CalAIM, for example, is a 5-year roadmap for fundamentally changing the Medi-Cal system. That grew after going and having conversations at the local level with counties, with behavioral health providers, with plans, with members, and them saying what we're doing is not working. So we developed a 5-year plan to implement it. That work is hard and complicated, but we do it through dozens of stakeholder engagements across the state of California. We have regional local learning collaboratives. We have also been working on getting $1.8 billion of planning and infrastructure grants out to local entities in order for that to be successful. So we have experience in building those complex policies and pieces. We also have been making fundamental changes on the behavioral health side, and I won't go into all of those various pieces, but we've been really working to improve, reduce administrative burden, and improve member experience. We have a long way to go still. We're working very closely with our county partners. What I'd say around the CalAIM behavioral health piece is we haven't just written a policy and walked away. We have, since implementing, we have iterated 3 or 4 times. We rolled out documentation reform. We heard quickly from providers it wasn't meeting the mark. It wasn't fixing all the issues. We have gone through a number of listening sessions, and we're getting ready to roll out, as many of you know, because we've had conversations with you, a next round of changes. We're trying to listen and iterate on complex policy. You never get it right the first time, but as long as you listen and keep iterating and moving, that is what we're committed to do, and that's what we have a history and past of doing. I would also just lift up BH Connect, as Stephanie mentioned, in regards to maximizing those federal dollars. There are many things that even this commission has been lifting up and making sure that we're scaling up across the state that we want to ensure that we are drawing down every federal dollar for. Things like first psychosis and early interventions there, ACT and other initiatives that Stephanie raised, making sure we're drawing down those federal dollars for workforce. For example, in that BH Connect, as she mentioned, we will be able to put up $36 million to draw down significant federal dollars. There's an 85% match on those proposals. We should not be leaving federal dollars on the table when it comes to increasing our Medi-Cal services and providing access to people across the entire state of California. With the behavioral health continuum infrastructure grants, we've been able to implement in both 21 and 22 initial planning grants to 18 tribal entities, 48 county behavioral health agencies. We have awarded over $1.3 billion to 132 projects, increasing access to 2,448 beds and 288,000 service slots. Those are dollars going out to individuals to build that infrastructure. I say these things to just say DHCS does have experience with implementing large-scale initiatives, complex policy, and as we continue to move forward in this behavioral health reform, we want to be partners, collaborative partners with our counties, with our providers, with the commission and others to make sure we do this very important transition correctly. So now I'll kind of do a quick walkthrough in regards to some of the areas in the BH reform where we're doubling down on transparency and accountability. We will have for the first time what we're calling an integrated plan. Right now, as you know, we have separate siloed funding streams with separate different initiatives. And this would require our county partners for the first time to do local planning across all of those streams, not just within historically MHSA or BHSA now, but also our Medi-Cal system. Where are those block grant dollars going? How is it aligning across all of those systems with providers to achieve our goals and outcomes for the behavioral health system in California? They would also be required to use data to inform that, local data. So local data driving where are our unmet needs? Where do we need additional reinforcement? Where do we need to enhance the system? That is the fundamental core of how MHSA was created and how we see BHSA playing a role in regards to doing these services in the future. So we think it's really critical that we are using data to inform that. They will also be required to stratify that data to identify disparities within the behavioral health system. We have been stratifying health disparities in the physical health side since 2016. We need to do that across all counties in the state of California to understand where our disparities are within the behavioral health system. And that would be a new requirement within this integrated plan to make sure dollars are going to the right individuals, providers, and to meet and close some of those gaps. So we're really excited about the integrated plan that is proposed within this proposal. We also have put forward what's called the County Behavioral Health Outcomes Accountability and Transparency Report. Essentially, this will be the first time, yes, the first time in California that we will have full transparency in regards to where all of the behavioral health dollars are going. Again, this transparency report is not only for MHSA or BHSA in the future dollars, it would be across all of our funding streams. So it would be across realignment or the Medi-Cal dollars, BHSA, all block grants, opioid settlement funds. It would be responsible for including the annual allocation, the annual expenditure, the administrative costs, and the annual and cumulative unspent state and federal behavioral health funds by each category at the county level. The sources and amounts spent annually as the non-federal share for Medi-Cal specialty mental health services and Medi-Cal substance use disorder treatment services. It would also include data and information on workforce measures and metrics, as we know that is critical to be able to meet the need of the moment. It would also include information on the behavioral health services provided to persons not covered on Medi-Cal. One of the biggest things we've heard from our county partners, and one of the core cornerstones of MHSA historically, is providing services in the community to individuals. So we want to have better insight into how many individuals are being provided that aren't on Medi-Cal, that have commercial insurance, that have Medicare or other insurance, so we can ensure we're holding all of our partners accountable, our commercial plans accountable, our Medi-Cal managed care plans accountable, and everyone for doing their part and or partnering with our county partners to ensure those services are reimbursed or covered, because that is their responsibility and they are being paid to do that in their premiums and capitation payments every single month. So we want to hold them accountable to doing that. It will also include annual data that will be submitted to us on service utilization, performance outcomes, measures across all the behavioral health delivery systems, including those disparities that I was mentioning earlier. So as Stephanie was mentioning, the behavioral health landscape has significantly changed since MHA was passed a few decades ago. When it passed, the Medi-Cal today is not the Medi-Cal that existed at that time. We have had the ACA expand. We have had extensive growth. We have added a significant number of both mental health and SUD services in Medi-Cal that did not exist when this was originally passed. Behavioral health parity has stepped up the game across the state to really make sure people are getting access to the services they need. Both the federal and state have doubled down in regards to the investments needed. And there have been significant federal rules that require the mandate around entitlements and protection of those for our beneficiaries, which we should be preserving and making sure that everybody has access to those critical services. One of the ways that we're going to double down within our managed care or county behavioral health plans is also looking at what is their administrative structure. One of the pieces in BH reform that hasn't had a lot of conversations is re-looking at some of those core components to make sure our county plans can be as successful as possible. We treat them and the federal government treats them like managed care plans. However, building that infrastructure at the administrative level, looking at that financial information, their information systems, quality improvements, looking at how they're managing their networks to ensure that we have adequate access across the entire state, looking at member services and care coordination expectations. So we're really excited about those components where we'd be also making fundamental changes to the contract between the state of California and our county partners to really make sure we are serving any and everyone that we need to. We would also note, as we've been going around and having conversations with amazing providers across the state and our county partners, as we continue to dig in, it's clear we're leaving federal dollars on the table. So really making sure people are understanding that most early intervention, if not all, can be reimbursed by Medi-Cal. You can draw down those federal funds for those services. For example, one of the things we did in CalAIM is remove the longstanding requirement that you had to have a diagnosis to be reimbursed for services. That is no longer. That changed in January 1 of 2022. You cannot have a diagnosis and be reimbursed for services as long as eventually someone either needs a diagnosis or you determine that is not needed and you can transition to other lower or other services within the community. We also know that every crisis intervention can also be covered by Medi-Cal services. So we really just want to make sure as we're having these conversations, we're maximizing all of the things at our fingertips to ensure people are getting access to really critical services. I look forward to having the conversation with you all today, answering any questions that we can, and continuing to collaborate as we work on this very critical initiative.
And I just want to close by saying, thank you, JC, and I know it's a lot of detail with all that discussion around planning and fiscal transparency, but the reason why I really wanted her to go into some detail is because this is where we can work together. Imagine all of the new information that we're going to have and the talents that you guys bring in terms of your evaluation agenda. And I think one thing I really want to underscore is I want to be very transparent in saying that it is not easy to be a Medi-Cal provider. And a lot of people don't want to be Medi-Cal providers. And I think that we need to have more conversations about that. And I think we need to offer technical assistance. We need to dive into, if we are placing our, I'm going to use a bad metaphor. If we're putting all of our ducks in this pond, right, and saying Medi-Cal is the future, we have to bring all of our providers with us. That includes our peer providers, and that provides our small providers. That includes our cultural providers that are working in very small organizations and working with a very specific population. But I also want to recognize not everybody needs to become a Medi-Cal provider. Part of what we're trying to do with this proposal is that when something is and can be billed to Medi-Cal, bill it. That means that there's more money left, particularly with our BHSA dollars, to do things that Medi-Cal can't do, just as it was envisioned 20 years ago. So I know that I want to recognize that there's just a lot of technical assistance that we need to do. We've heard it from early childhood people who care about the 0 to 3 and 0 to 5 populations. We've heard it, people who are working with older adults, people who are working with all sorts of specialty populations, particularly our small CBOs. So we acknowledge that, and I think we're committed to figuring out how to resolve that. And frankly, this whole exercise and all of the conversations that we've had with many people at this table and people in this room and people across the state is, hey, it's not easy being a Medi-Cal provider, and we need some assistance and support and training and technical assistance, and it's got to be easier to be a part of that Medi-Cal family. So with that, I think we're done, and I'm not sure if we take questions now, but we are here to listen to our other colleagues at the table. So thank you.
Thank you, Stephanie. Thank you, JC. So at this time, we will ask for commissioners' questions or comments, and then we will have another group of presenters. We'll do the same thing, commissioners' questions and comments, and then another group as we go through the panel. So at this time, questions or comments for Stephanie or JC, please.
I can go first. Oh, what was that, Commissioner Brown?
No, good.
Okay. Thank you, Stephanie and JC. We talked yesterday, and thank you for making a space for the peer community. I just wanted to go on public record with some of my concerns. You probably already heard yesterday. Currently, in its current form, this plan will significantly impact peer providers. As you know, a lot of us, our small CBOs, heavily rely on MHSA funding for our community centers, our ethnic services, our advocacy services. Particular, like a lot of us, particularly myself as a provider, we do not bill Medi-Cal, as you noted, that, and I think there's a major disconnect between the state and the counties, and the level of work that is going to be needed to take on that technical assistance to get people prepared. I'm currently a recipient of the Peer Workforce Investment Grant, which is a state-funded grant to bring peer organizations to be able to bill Medi-Cal, but we have, I brought these concerns to the state 2 or 3 years ago. There's still not any strategies or solutions. I just think it's a heavy feat to try. I'm not saying it's impossible. I know everything's possible with work, but to bring the counties on board with, getting all of us providers to be Medi-Cal providers. I also wanted to acknowledge that the proposal gives more seats to the family members as opposed to the equitable number of seats to, we actually will lose a peer seat, I think, under this proposal, or have only one representative. So would definitely want to make sure that peers are represented because we are the representation of recovery. I think that that's what's missed out. If there are no people that recover from the system, then is the system actually working? If we're not at the table? Another concern that I had, once again, is just making sure that there are peer respites, other alternatives to locked treatment. I think I'm happy that the governor has taken this approach to modernize the mental health system. And I'm speaking for our constituents because that's what I'm here to represent, the peer community, that the peer community providers who really embody recovery, who navigate the system, does not have a voice at the table I guess now that it's done, now we have a voice, and now we have to read through 300 pages of legislation. There's so many changes. But yeah, I think that those were my major concerns, our membership, that we, like right now, if this is in place, we'll be wiped out as providers. So just want to put that on public record. But I've already expressed that to you, and I'm looking forward to working with you all.
Thank you, Commissioner Chambers. Commissioner Brown?
First of all, I want to say thank you, Stephanie and your team and everyone from the state for being here today. We appreciate you being here today and previously to hear our concerns, and I would hope that you would please take the message back to the governor and to his staff that we appreciate very much the amendments and modifications that have already been made to this proposal, and certainly think that these listening sessions and opportunities to hear from a variety of stakeholders will be very beneficial in terms of bringing back some additional things that may help reflect some additional tweaks that may benefit the proposal, both the legislation and the initiative. I just wanted to make a couple of comments. First, with respect to the substance use disorder elements, I couldn't be in agreement more that we need to put more emphasis and more resources into this problem, but the approach to the proliferation of dangerous, illicit, and often lethal drugs like fentanyl and methamphetamine has to include a multi-pronged approach. It can't be done strictly by one approach. There was a major pushback a number of years ago against the so-called war on drugs, and a pushback from the enforcement side of it to the point where I think the pendulum has swung too far the other way. And I think realistically, if this fentanyl and methamphetamine problem in our state that is killing people at epidemic proportion is going to be brought under control, it has to be through a blend of not only prevention and treatment efforts, but also enforcement efforts that work to complement those. We need to have more state resources. And this is, although not part of the act or the legislation rather, or the MHSA or the other. I think the message needs to go back that, you know, the state's resources used to be considerable in this area, but they have shut down the Bureau of Narcotic Enforcement, which used to be the catalyst that led multi-agency task forces throughout the state that addressed major dealers and interdicted major amounts of drugs that were coming into communities. And that's never been more important than it is now with fentanyl, with the lethality of this drug that is just claiming far too many lives in our communities. So if you could take that message back, it would be appreciated. Another area that I just wanted to mention is that although the proposal has some great key areas that it focuses on, primarily in terms of homelessness in particular and substance use disorder, local counties are operating from a standpoint, including the one I work in, Santa Barbara County, with a lack of particularly acute and subacute beds in our inventory, which has been pointed out in our county in several studies, for example, that were just made known. One of them, including the RAND Corporation, did a study that showed, you know, we have a county of 450,000 people. We have 16 PUF beds in our county primarily due to the federal Medicaid restrictions, and I want to just put in a big pitch for the IMD exclusion that is really, I think, necessary for us to, in this day and age, move forward with a different approach where we could expand the size of those facilities and provide much better health care services. And in our county, we're hearing this from the advocacy groups, from the family groups, and from others that really are pushing very strongly for this. So perhaps some thought to, in terms of amendment to modifying the ability of a county if there is a need. If there's already, for example, in our county, we're already working very closely with Dignity Moves and with others to put transitional housing and potentially long-term housing for homeless people, many of whom are dual diagnosed and have co-occurring substance use disorder. There may not be as much of a need in some counties for the types of beds that this would, as currently proposed, offer, but there might be, and indeed is in our county, a need for some other types of beds that wouldn't be funded through this proposal. So that's something I think, again, is food for thought. And then I also just have a quick comment with respect to Ms. Cooper with respect to the Medicaid reimbursement. There's some major concern for our county and others that have co-response programs that involve law enforcement working side by side with behavioral wellness professionals. And the directive that was issued from your organization with respect to Medicaid reimbursement specifically excludes those teams that have law enforcement as a component of the co-response. And this, I think, is a reflection. I'm not sure what the genesis of that is. If it's, I suspect that there's some interpretation of some federal regulation on that, but it's reflective, I think, of a bias against the model involving law enforcement. But I'm here to tell you that it works, and it works very well, and is very well received, and it's keeping mentally ill people out of our jails. It's getting them into proper treatment and services, and that's something that really needs to be fixed. That is a problem that I think potentially could move counties away from an effective model to one that may not be as effective strictly because of the finances involved, and there's the reimbursement potential. So, thank you.
Thank you, Commissioner Brown.
Madam Chair.
We'll have Commissioner Tamplin and then Commissioner Rolette, please.
I also want to thank our Stephanie and JC for coming here and making time to hear from us and the community about these changes, that the proposals. And I want to agree with Commissioner Chambers and Commissioner Brown with their comments, and particularly with the voice of the peer community and the community that's the providers that are going to be impacted around these changes. One of the areas that hasn't been mentioned yet is, and you shared about innovation and innovation. Currently, the process is that those resources are separated and it comes through the commission. And I think that sometimes what's missed is that when the community engagement process at the local counties are happening around innovation and ideas and specific things that each community is trying to address, that opens up the opportunity for so many community providers to engage with the county, to inform the county of what are the needs, and then and partner to bring those ideas to the commission, right? And then ultimately set that aside for a process for them to even get contracts with the county. I think losing the way it's set up right now and just lumping it in with competing with other valuable resources is a huge loss for our state. I know just in January, Alameda County, I am an Alameda County employee, presented a wonderful innovation proposal that focused on the reentry justice-involved population and creating a peer continuum of care. Because of that, we're now able to release RFPs for our community for more peer programs to participate and provide these services. But that really does happen through this collaborative approach with the commission involved. And I think that when resources and the way the structure of the money is allocated and assigned by the state in this proposal, that's going to get lost. If it's not a mandate the way it is right now, and I'm not saying it's going to get lost everywhere, right? But it's probably going to get lost majority of the places, because when we're struggling with trying to get, of course, always meeting the needs to pull down the federal funds, but innovation is going to get lost with that process. And I think that would be a huge loss for our whole state. So I hope that innovation stays as the way it is. And I really appreciate, JC, you talking about, of course, and Stephanie, leveraging Medi-Cal dollars and valuing the peer support and other fields that are working to now be able to bill for Medi-Cal. There is a lot of need to support that transition process. And I think one of the other areas that it's important to elevate, and in my opinion, is I think there's some confusion across the state. There's a lot of support for community health workers, and that's wonderful. But people are lumping community health workers and certified peer support specialists into one. And so for beneficiaries and folks going to get services, they may interact with the community health worker or a person that has that title and not immediately know if they have a title as a peer supporter. And that really, again, not recognizing it as a separate field and putting the same amount of support and recognition that I think the community health workers deserve and have been getting to the certified peer support specialists means we might again get lost in the weeds, and really just needing that support for that elevation. And there's always going to be a advocacy from our peer community, because we've seen that peer respites are so critical in preventing crisis and increasing access, in supporting family members also who are struggling and in crisis too. So it's, again, you don't need to have a diagnosis, but you're experiencing these things, and you want to go to a place where you have a certified peer support specialist that's going to meet you where you're at. It's not going to be in an IMD, because IMDs are right now not meeting the standards, in my opinion, and many peers' opinions of what we consider quality care. And so we really, we're telling you, we want more peer respites. Can we move in that direction more with more resources for that? And again, we're on the same page about, addressing homelessness is so important. I'm not sure if, this is addressing the fact that the housing crisis, the housing cost it's not being addressed. So we're still gonna have this issue of homelessness, because in California, it costs too much to rent here or live here, and until we fix that, I don't know how we're going to help and fix the homelessness issue. And of course, the UCSF survey that recently came out highlights that, and just so it's not just Mental Health Services Act that should be supporting this kind of stuff. We have bigger things that are around housing that is apparently not going to go away until we do something bolder in that area. So thank you.
If I could, Commissioner, I just wanted to raise something just to make sure that the broader commission understands. On your comments around innovation, it would be one of the continued requirements of the 3-year planning process in that integrated plan, that counties would still be responsible for engaging local partners. One of the things I heard you say is that we're losing the local engagement around where innovations could be lifted up. And so I just wanted to make
Thank
sure
you.
you were assured that as a part of that integrated plan, it would include where they're going to do innovative initiatives, processes, and grants to providers or community-based organizations within the dollar infrastructure across all of the buckets. So I just wanted to make sure
appreciate
that you
that.
didn't.
No,
it
thank you
was
for that
the local
clarity.
engagement
Thank
part,
you.
sure. Yeah.
I really appreciate that. And there's, I mean, I guess I just am really appreciative also when it comes to the commission and the wider community is aware, I mean, people have more access to this body, you know, than sometimes locally, when I'm not saying that you know, locally that can't change, but this has been an important role from learning about what's happening and hearing it and asking questions and getting the public to ask questions. That has been really valuable and enriching, and I think also informative for other counties so that we don't remain in silos. So thank you.
Commissioner Rolette, please, and then Commissioner Danovich.
Good morning, Commissioners, and thank you to the presenters. I want to, Commissioners, acknowledge that there have been a number of opportunities to engage Stephanie and JC in conversations related to this. I appreciate the collaborative approach that has already been demonstrated. The opportunities to engage and ask questions are reflected in some elements of the comments that have already been shared today. So Stephanie, acknowledge, thank you very, very much. I appreciate that. I will also add that there remains some ongoing concerns, especially by providers of behavioral health service, which my colleagues on the panel will certainly speak to. So those concerns include, while again, I underscore what is already been said about the importance of individuals with substance use disorders getting important, timely treatment, there should be and continue to need to be discussions regarding what I see as fundamentally when there is a shift in eligibility, how that will be accounted for or even paid for. And I know that there's been discussion about that. I know that there's been opportunities to have input about that. However, ongoingly, we want to make sure that the expansion of eligibility does not adversely affect necessary or important services that are already being provided. And one example, Commissioners, in one of our discussions is regarding existing outpatient services, some of which are being paid for not by PEI or innovation funds, by other MHSA funds. And specifically in Sacramento County, as a specific example, there was a recent very effective expansion of outpatient services, some of which are funded by MHSA funds. Well, we want to make sure that this modernization, and again, there is, as Commissioner Brown might say, there's a lot to do with the details. I do not object to modernization. However, we want to make sure that it does not adversely affect the existing continuum of care that is very important for individuals who are recipients of Medi-Cal and need those outpatient services. And then lastly, I'll emphasize, and I'm sure it's going to be talked about by the panel today, FSP. A lot of discussion and emphasis on FSP and its role in the modernization. And I know, and I've said this before, but I want to say it for my commissioner colleagues and for everyone who's listening, the importance of understanding the geographic differences of FSP services, the importance of having outcomes being an embedded feature in FSP services. And then again, as you have alluded to, Stephanie and JC, the workforce challenges that we are all facing today, and how those workforce challenges get inculcated into this new modernization around FSP, because we don't want it to have a deleterious effect on what is currently an effective FSP model in those municipalities where FSP is really working. So those are my comments. I'll go back to what I said in my preamble. I want to endorse the ongoing conversation and opportunities to have conversations with the administration. Thank you very much for that, Stephanie and JC. And I look forward to hearing what the other panelists have to say about these topics.
Thank you, Commissioner Rowlett. Commissioner Danovich, please.
Yeah, thank you. First, thank you both for the conversations that we've had leading up to this meeting and for being here today. As I've mentioned it before, I appreciate that we clearly all have the same goals. And I would, posit that in principle, consolidating resources through an agency makes complete sense. However, in practice, there's so many challenges. We've spoken a lot about innovation. I just want to highlight the purpose of innovation is really to facilitate system transformation rather than just incremental growth, because of the notion that the system itself, growing in the way that it has been, is just not sufficient to deal with the size, the enormity of the problems that the population faces. So the end goal is to find new solutions and new mechanisms that really deliver improved care to people on the ground. You know that. I think the question is how. Substance use disorders, which is really close to my heart, is one of many, many examples where there's need here. DHCS has achieved so many important things in this space. I think adopting standards of care, the ASAM criteria, has been huge. CalAIM, has been huge. And yet, at the ground level, at the county level, most counties don't have the continuum of care that's specified. Most providers of care aren't meeting the standards that are required within existing and accepted standards of care, including the ones that DHCS has promulgated and which we all support. There is so much need for transformation of that system in order to enable that system to meet what we have already established as requirements for it. I think what MHSA did and what the commission has tried to do for better and for worse, or maybe not for worse, but not always at the level that I wish we could, has been to help shape the system by providing another mechanism outside of the agency to help facilitate change and promote change. What I would like to see, since our goals are the same, is strengthening of the commission and the MHSA, because I worry that with the consolidation of resources and with some of what's in the legislation, we're going to soften or weaken this extra agency mechanism of helping to shape the system and achieve the shared goals that we all have. And I worry also, one of the big challenges the commission has faced has been transparency, getting data to understand where opportunities are and where to be effective. And we all struggle with acquisition of data, but it's been even hard between our organizations and entities to do that. I worry about transparency and I worry about the commission's ability to support our shared objectives. As we look to amendments, modifications, of this, I think that that's really what we need to keep our eye on the ball on. So thank you, and look forward to continuing to support this process in any way that we can.
Thank you, and thank you specifically for that comment. We are looking at we are looking and making sure that with the next round of changes that we ensure that you guys are going to get the data that you need to do the work that you're supposed to be doing. So appreciate that comment. Thank you.
Thank you, Stephanie. Any other comments, questions? Please, Commissioner Carnevale.
Thank you for being here today. I appreciate the spirit of wanting to collaborate, but it's very difficult to collaborate baking a cake when the cake's already baked and we're just talking about where we slice it. I'm the business representative here, and in my world, plans happen very differently. We're all agreeing on the problems, but from problems, we then try to go to objectives. What are the outcomes we're trying to achieve? We then establish a framework that we can operate in, and then strategies that we can implement to accomplish those outcomes. And then at the end comes the plan. And in this process, for some reason, we've gone from the problem to the plan, and we're missing the entire middle. There's a missing middle here. And you can't explain, except through magical thinking, what's going to happen here. We're going to wind back the clock 20 years, and we're going to tell the counties to go innovate when we spent 20 years learning that that doesn't work. That's why the commission exists. That's why we've done all the things we've done. So I don't understand. I don't know how to connect these dots. It doesn't make any sense to get into the details. If you were in my company, if you came to my company and you presented this plan, I'd tell you to go back to the drawing board. But you yourself had said this is a massive change, and yet we're rushing to try to implement something that doesn't seem very well thought out to me. And I don't know how you're going to save that from us sitting here in a couple of years and realizing that this plan created more problems than it was intended to solve. And that's what it appears to me. So I don't have enough information to vote for or against this because it's just missing. Thank you.
Thank you, Commissioner Carnevale. Any other questions? Please, Commissioner Robinson.
Thank you. I'm intrigued by the comment that it's not easy to be a Medi-Cal provider. I was a clinical psychologist some years ago in a different state and had the same kind of feeling like it was tough to be a Medicaid provider. So can you elaborate a little bit more on like why you say that and maybe what we're doing to address it?
I can start, but I think JC would probably do a better job than me as the state Medicaid director. But, what I have been hearing, to be very frank, is we have organizations that may have volunteers that are delivering services, that they're doing critical, like mission critical work. They could be reaching out to faith communities. And I think we have other, as you had mentioned, Rochelle, Commissioner Chambers did an excellent job talking about, I'm very familiar with her organization. We want to work with that organization on psychiatric advanced directives and some of the work that you guys have led in a different project. And so, these are organizations that are working with maybe small budgets, maybe they don't have any clinical staff, and now we have this benefit, and it's not even just the peer benefit, right? I mean, it sounds like your organization is contracting to provide wellness center services. In my understanding, I think those services to a certain extent may also have a Medicaid dollar, not everything that's happening at the wellness center, but some of the things. And so I think what we're trying to figure out is how do we make sure that individuals who may not, have ever upheld a contract, or I don't know if that's the right term, JC, but how do we support them to have that capacity? I mean, there's billing involved, there's more administrative, I'm sure, work, and part of what we're trying to do with that administrative process is make it easier. I'm sure our providers will talk about that, so that it's less burdensome and that people don't have to spend so much time doing, paperwork, and they can spend more time working with clients. So I think that might be, I would imagine, as a clinician or as a provider, as a peer, that's very frustrating that you'd have to spend time doing that. I think from my experience when I was at the Department of Corrections and Rehabilitation, I know it was also hard. It was a process, and we needed to work with our providers. I mean, maybe even Vic could speak to this at a certain point, because it's still very recent and fresh in our memory, bringing in our SUD services to our Medicaid system. There were a lot of SUD providers who were not, Medi-Cal certified, and so I don't know if that's does diligence in answering your question, but I just wanted to say something because it's certainly something that we're hearing, and I'm very, very interested in hearing more and learning more from. Especially since it is mission critical to this administration and to our, at least my secretary, for peer providers and to be an essential service and play an essential role in California's behavioral health system. So to hear that they're concerned that there's no place for them anymore with this proposal is very concerning to us in terms of wanting to figure out how to resolve that. And I don't know if you can help me with this one a little bit.
Yeah, I mean,
Thank you.
I think, when when a community-based organization or an entity, and we are learning this very much through CalAIM and our expansion of community-based organizations coming to provide Medi-Cal services, there's a lot of steps, right? You have to become enrolled as a Medicaid provider, and there's a lot of information you have to provide that we've seen as a large barrier for many people. We've come a long way in improving some of our efficiencies around provider enrollment, but we still have some room, to be honest with you. We know that, and we were working with people to streamline our provider enrollment. We've tried to improve that. I think some of the other pieces that Stephanie was mentioning, documentation reform, that just rolled out. But oh my gosh, I still remember when we were doing CalAIM back in 2000, and I think it was around 2019, I sat in a room with behavioral health providers in counties where they walked me through some of the long-standing old regs that were just creating insane barriers for them and the amount of time they were spending on documentation based on old audits and all kinds of things. They were scarred by it. I'll just be honest with you. It was I walked away, we did probably 4 sessions with them. And I walked away and I got my team in a room and I said, well, we have something to solve, right? And we rolled out the first round of documentation reform in behavioral health, and we still have some room to grow because there's some federal regs that are creating barriers. We just advocated to the federal government to remove some of those federal pieces, and they approved it in the last month.
Good.
So we are trying to break down those long-standing documentation barriers that I think have really been a burden on those Medi-Cal providers. And then the one that Stephanie's mentioning, just a few more, because I think it may help. Is the contracting with counties. So the structure in the state is we delegate our responsibility to counties, and counties all look different in the state of California. So some counties keep it all in-house, some contract out, some do a hybrid. And the federal government considers those counties in their eyes under federal regs a managed care plan. And so they have to have a contracted network, which means you have to have a contract, you have to negotiate rates, all of those things. And we used to have cost-based reimbursement. That's another thing CalAIM fixed, right? Where you don't have to have all that administrative burden for a provider to document your costs and do those pieces and that back and forth. That created a lot of barriers. So I think CalAIM's solving, or in the process of solving is what I would say, because it's an evolution. Some of those. But as we've said, CalAIM is a 5 to 7 year roadmap. You don't make change overnight. This is fundamental at every level. And then I think the other thing that we're seeing is, there's not even federal clear behavioral health quality and outcome metrics. We don't have a way of measuring quality and outcomes nationwide, not just California. So everybody's kind of making it up as we go, which is not the best place to be, just to be honest with you, right? Like that's not an ideal situation. So I think all of those factors play into why it's hard to be a Medi-Cal provider.
It flashes me back again 10, 15 years, and it's kind of scary that we haven't progressed further than that. So I appreciate your comments, and I would underscore the need to try to break down those barriers and not make that an ongoing narrative, because it was difficult a long time ago, and if it's difficult now, we're just undermining our plan if it's not easy for providers to provide. Now, let me put on my current hat. Current hat is I represent the commission because I represent a large employer. And so workforce challenges are extreme for us. And so it's not having enough nurses, and certainly not having enough behavioral health providers is critical to the success of the plan too. So I'd appreciate any comments you may have about what we're doing to address that, and how will that be addressed? Because I read the comments here, and I see it's identified as an issue, but it is a gargantuan problem for us as a country, not just for mental health, but industry at large. And so appreciate any comments and any thoughts about how we can do better with that, because it's a big problem.
Yeah, so in the proposal, we do earmark that there'd be a portion of dollars being directly focused on workforce, which is critical, which means there are dollars that would be directed towards increasing access to workforce, the pipeline. I think one thing I would note, and we mentioned it a little bit earlier, and then maybe walk through some, HCI is also providing a large number of workforce dollars. One of the things is making sure that we're leveraging federal dollars when it comes to workforce. Historically in the state, we've only used state dollars for that. And there's an opportunity with the BH Connect waiver that we're getting ready to come out for full public comment, official public comment and hearings on after many, many months of collaboration with everyone, adding that workforce component where you can take a small amount of state funds and match with about 85% federal funds. I mean, maximizing those opportunities, and those are direct dollars that we would work to build out workforce pipelines across the state, $2.4 billion, as Stephanie mentioned. It would also include some dollars for the counties to be utilizing, but we know workforce is a problem, not just in behavioral health. We are seeing it across the entire delivery system. The impacts of COVID has magnified that significantly. And so we know and understand the urgency around the workforce piece. And so I think that's why we're trying to make sure it is a large component of this proposal and what we're putting forward.
Yeah, I'd even just, I mean, you're probably thinking this already, but I think broader in terms of how we define workforce, because just, you're talking about building beds and supportive housing, construction workers. I mean, do you have enough, people to build the things that you need in the healthcare industry? Just in this area, between the four systems, we're talking about over $10 billion in investment, capital investment in the next few years. I worry that we don't have enough construction workers, not let alone nurses or providers, but just, so I would encourage you to think real broadly about it.
Yeah.
Thank you.
Really appreciate that. And just so I want you guys all to know that we do regularly meet with our labor, I forgot the name of the agency, but our labor partners, they're the ones that helped us actually design some of the ideas behind the components in our current workforce initiatives, both as part of the Children and Youth Behavioral Health Initiative, which includes an SUD Earn and Learn program, and to do other kind of apprenticeship programs. That was adopted from the incredible work that the Labor Department has done with the building and trades to bring to really start with not like, let's give you loan forgiveness, or let's give you, I could talk about this all day as someone who's still paying student loans as a social worker, maybe for the rest of my life, but like you can't, it has to be upfront, and it has to be, you have to trust that that person is going to accomplish a goal and support them throughout the process, and support the CBOs and the other clinicians that are providing supervision and support and training to these folks. And I think the last thing I just real quickly would say is that I hope it's an area that is of interest to this body. I know it's a great interest to our Behavioral Health Planning Council. They've been really leading on some of these ideas for decades. And we really want to think about the workforce of tomorrow for our own behavioral health workforce. We kind of have started that with the concept of behavioral or now wellness coaches as part of CYBHI, but we really have to think about, and this is particularly important for SUD, what do we need to make sure that we have people who can deliver the type of services that people actually use and want, and to make sure that these are people who are reflective of the diversity of California. Sitting here as a middle-aged white woman who's a social worker, we don't need a whole lot more of people like me. We need a lot of different people. So it's going to be a tremendous effort, and I'm really looking forward to a lot of collaboration with many of the people at this table on how we design that.
Thank you,
going
Stephanie.
forward.
We're going to go ahead and move on. I know Commissioner Tamplin wants to make a comment, and then I'll make a comment. We're going to move on to the next panel so we can just make sure. And if you want to stretch out maybe on the sides, it looks like you guys are, and I'm feeling for you. So maybe at the end, move. I'm just trying to make you more comfortable. If you need water or anything, let us know, please. We will gladly take care of that. Commissioner
And
Tamplin,
thank you,
please.
Chair Madrigal-Weiss. I just want to make this really quick. I think it's probably not the right timing, in my opinion, and the March ballot, that's less than a year from now. It feels so rushed, and to Commissioner Carnevale's points, like we're really, I mean, his points, again, ditto, all of that. It just, I don't know, I think we also have less voters contributing to this, and so being able to vote on this if it does go to the voters, and March is, again, less than a year away, and I don't feel like, I think the proposal's got a lot more work to be done on.
Thank you, Commissioner Tamplin. And I, too, agree with what Commissioner Tamplin's saying, and here's my concern. I just want to say this. We're about a year and a half out from a global pandemic. We don't know what we don't know. I think the tsunami's still coming in, and we are ready to put in this huge change when the issues are still happening. Fentanyl that's going on. You know, I work with schools and suicidal ideation and the things that are happening, the behaviors, everything that's going, we don't even know what we don't know, and yet we're willing to make this humongous change and speaking to things that I don't even think have been identified. And I don't think we question that, you know, you will build out the systems. I think it's more of a question that there isn't a concrete implementation plan. And I know it's hard to build the weeds. I get it. I think those are kind of the questions we've had. But I do want to say this. The governor has made historic investments in school mental health, yet we do not have a state-level home for ongoing commitment to school mental health. And I don't mean CYBHI. I get that. I'm talking about specifically state leadership for school mental health. It's nowhere identified. I know this commission has done tremendous work around that, so I will again say that for the record. Please look into that. And it goes right back to what I'm talking about. There's so many things happening with our youth in our schools, and we can do so much around PEI with our schools. So I want to say that. So with that, I am going to move us along. JC, Stephanie, thank you for being here. I'm not going to overuse the word collaborative, but you know, let's just keep talking because we do want to build together. So thank you for being here. At this point, we are going to move on to invite, and please, I hope I pronounce the names correctly. I am inviting Vitka Eisen, CEO of Health Right 360, Leandra Clark Harvey, CEO of the California Council of Community Behavioral Health Agencies, and Jolie Onodera, Senior Legislative Advocate for the California State Association of Counties, to present first, and then they will pause for commissioner questions and comments before moving on to the next panelist. So if you would, please.
Since you called my name first, I'll go first. So I'm Vitka Eisen. I'm the CEO of Health Right 360, and we're a large behavioral health provider providing in multiple counties, serving very low-income communities. And the largest percentage of what we do is substance use disorder treatment, and have been doing so. I've been in that field for 35 years, and I'm also a former drug user and was a beneficiary of publicly funded harm reduction and substance use treatment services a zillion years ago. I am no expert on the Mental Health Services Act. In fact, I was invited here and I was like, yeah, sure, you want me. And I did a lot of homework, okay? I mean, I read all the briefing papers, I looked at like endless webinars, and I was like, I reached back out to the folks who invited me and I said, there's no way I can speak to 18% over 15%, and this is changing to 35%. So please don't ask me math questions because I won't answer them. But I do know a lot about substance use disorder treatment in the community-based substance use disorder treatment and people who use drugs and the life that what they have experienced prior to and since MHSA became law. From my perspective, adding substance use disorder as a benefit, as a condition covered under the Behavioral Health Services Act is rectifying a long ago mistake or error. I don't know if it was a mistake, it was probably intentional. It is rectifying something that should always have been included. And working in the field then, we said so then, and I say so now. If you look back, if the Mental Health Services Act was passed into law in 2004. In 2004, California still had the highest number of people in prison. And about maybe 80% of those people, up to 80% of those people, were there for, had a condition related to substance use disorder. That group of people were primarily Black and brown folks, and that is where they were sent to get their care. At that time, the state prisons, had probably the most robust statewide treatment system in California, and that's tragic, and that is absolutely wrong, and it's an inequity. And it wasn't until Drug Medi-Cal, which was long after the ACA was passed, and long after the expansion of Medi-Cal, for low, that was be income-based. And finally, the waiver that was passed that created kind of revolutionized substance use treatment across the country because it made it possible to pay for a full scope of care for people with substance use disorder. It wasn't until then that we were able to create, not without gaps, but community-based systems of substance use care for people based on income. Because again, part of that was the prison system. So I'm really pleased to see. Now, there's no way that I want to be part of a conversation that says, well, we have to sacrifice children, or we have to sacrifice, like, we should not be talking, that's like how systems break down is when we're pitted against each other, when when there's a scarcity of resources and we're pitted against each other. But I do want you to consider that those individuals with substance use should have been a part of this all along, and it caused incalculable harm for a decade, at least a decade, until drug Medi-Cal, any attempt was made to rectify that. I also think that most of the people that we serve are people who have no housing or unstable housing. And I do believe that housing is healthcare. And that we have plenty of data to show that people who are unhoused, simply by the fact of being unhoused, have poor health outcomes. And that just housing people alone increases health. And that if you compare that with some kind of wraparound service, that even more so. And what most important is to maintain people in housing through services. Our headquarters is in San Francisco. I'm up in Sacramento a lot. And we see the condition of people. I've literally watched people's condition deteriorate as there is less and less affordable housing. People who use drugs. Listen, people have always used drugs. I mean, I used drugs 40 years ago. Most of us we could afford housing. So you stayed housed for the most part. People don't have housing, and they don't have a car to use in, and they don't have a tent, and they are on the streets, and that has caused visibly, I mean, you can watch a massive deterioration in their health. And it also causes an increase in drug use, particularly if you think about people who use stimulants, will use stimulants because if you have to sleep on the street at night and you don't feel safe, it helps you, A, not have to eat, and B, keep track of your stuff and make sure you're safe. People who live on the streets are subjected to a great deal of violence. So housing is health, and in any way that we can continue to support people's housing, that will improve their mental health and their substance use condition. One of the things that Drug Medi-Cal did allow us to do was to add a benefit not through Medi-Cal, but post residential treatment services for people who are unhoused, was to pay for recovery bridge housing. But that is a benefit. I think the counties mostly use block grant for that, SAPD block grant. But as a benefit, in many counties, it's pretty limited because it doesn't go far enough. And so they have 3 months. So if you have 3 months of residential treatment and 3 months in transitional housing, and you don't have any supportive housing while you continue care and outpatient after that, there's likely to be a deterioration. There are other gaps in care under Drug Medi-Cal that I think could be alleviated using Behavioral Health Services Act funding. For example, I believe that people should get, that there's like I think many of you share this, no wrong door. People should get the care where they show up. So we operate, for example, a drug crisis center, drug sobering center. We have some people who show up there a lot. They show up there many times. They stay there for 10 hours. They get some sleep. They get some to eat, get some counseling. We get them to other services if they want it. Now, some of those folks would really benefit from like a more wraparound intensive case management or full service partnership. If they show up at that service, then we should be able to generate an FSP type program for them, and we should be able to be the provider of that services because we've built a relationship with them. And so I think this may allow us to do things where you can really meet people exactly, literally, physically where they are and bring them care. Let's see. I know there's concerns. I think some of the comments that got addressed to me were in writing, where there were concerns about the integration of substance use and mental health at the county level. And I believe that's a challenge that the state is already working on. I've been to numerous like webinars and listening sessions and discussions with with DHCS that there is a plan for integrating those counties. And I think that's really important. Listen, it's different, but I think it's critically important because, again, people need to get the care where they feel comfortable and where they show up. And the fact that these things operate as entirely separate funding pools and separate plans is highly problematic for the people who actually are receiving the service. In terms of prevention, I would love to see prevention service expanded for children from a harm reduction approach, for children who were prenatally exposed, in particular to alcohol. So any children who are prenatally exposed to alcohol have a higher risk of mental health and substance use issues if unaddressed at an early age. I would love to see this done in such a way that there is no stigma to the mother and there's no fear that a mother loses her child, because that's how kids don't get services, right? And that's how the family doesn't get services. We need to remove the stigma from that. And then that is an incredibly high-risk population, in particular, that I would love to see that we focus on as part of the prevention and early intervention programs. Two final things. One is, I understand the desire for county-based local systems, and I also know that that does not always work for a number of reasons for the people we serve. And it doesn't always work because sometimes the county doesn't have the full range of services that the people have, right? And I also know from a substance use disorder treatment perspective, a lot of the people we serve are transient, right? So you may have registered for Medi-Cal at some point in Mendocino County, and you'll show up in Santa Clara County, and that's an interruption in care. And obviously, from a substance use perspective, we're not going to tell people we'll go back to Mendocino County because they're just going to turn around and use drugs on the streets and maybe die, So I understand there's upsides to county-based local systems, but there's definitely downsides in terms of continuity of care. And there's also some counties. The state has had to step in over the years with some counties in order to support programs that counties themselves, even if they were evidence-based, counties wouldn't support. The best example of this is methadone treatment. Methadone treatment is a highly effective evidence-based intervention. It prevents people from dying of drug overdoses, intervention for people who use opioids. And yet there are counties who are like, not in my county. And so the state would have to directly contract. This is also true for harm reduction services. So I want to say that there are times when regional model may be the best model. And it's also true that there are people who have a substance use disorder who actually desire to relocate to a different county because they are very triggered in their own county. They want to restart their life in treatment, create new services and supports. And I think we need to support that. Finally, regarding workforce, the SUD workforce, I will say, we have the highest percentage of peer workers in any behavioral health system. I'm a former drug user. Leadership in our organization, many of them are former drug users. Many of our frontline counselors are. Many of our frontline counselors have moved up through the years into positions of leadership. So we actually employ probably the largest group of peer people with lived experience. But the workforce issues are in crisis, and I would agree with that. And I will say at the end of the day, we can do all kinds of I support pipeline programs. We operate some really innovative ones that have been supported by both DHCS and HCI. But at the end of the day, if you can't make a livable wage in the field, why would anybody want to work there? And so we join with our labor partners and say, we have to create a rate system that supports a livable wage for behavioral health workers. Thanks.
I think I have a PowerPoint presentation that's being loaded. Good afternoon. Oh, are we afternoon? Oh, still morning. Good morning, everyone. And I apologize for my late arrival. I was at another state board meeting presenting, so I was rushing over here. Thank you so much for the invitation to join you and talk about CBHA and our members, and really share feedback specific to what I've been asked to discuss today, which is around FSP. Our organization is very invested. Am I telling someone to advance the slides? Because I don't have a clicker. Thank you. Our organization is very invested in any changes to the Act. As many of you know, our early leader was a co-author. And we've not taken a position on the proposal at this point, but we are so grateful to the administration for engaging us in ongoing conversations and the changes that are being made as you hear concerns from various stakeholders. So our members, Dr. Eisen and Commissioner Rolette, are experts in the field, and it really represents the diversity of our membership. Our members have 20-plus years of experience with FSP, and as these survey results suggest and reflect, our members fund many services through MHSA funding. I could spend my entire time here today, and I think you've allotted 5 to 7 minutes, discussing the innovative and really critical services that our members provide. But I've been asked, and I'm a good student, to speak about two very specific areas of the proposal as it relates to FSP, so I'll do that. But as you can see reflected on that slide, our members are 76% of some of the services would fall within the CSS bucket, PEI, innovation, and then workforce and education. So this is how our members across the state are using MHSA funds. And it's just, I think it's really important to point out that a large percentage of the funds are really around PEI and CSS, and illustrate that to you today. One of the questions we were asked to, reflect on was the information around the integrated plans and the annual reports. And I surveyed my members quickly and got some quotes from them. So this is really in their words. This is what I'm reflecting back to you. I think that's what's most helpful. And overall, it's really, as you'll see there, it's all in the method, right? And of course, we want accountability. Of course, we want to support all of the statements and the efforts here. It's critically important. So the idea of greater transparency and accountability is critical, but as long as it does not increase administrative burden. How do you do that, right? So I think that there has to be a lot of thought. It's one thing to say the buzzwords, accountability, but how does that really operationalize? What does that look like? And there's a lot of work that needs to be done here and done quickly as this proposal advances. So to this end, accountability, it just has to be so specifically outlined here. And as you can see on the slide, members are concerned about administrative burden, a system where all of the agencies can upload their data. So really talking about, as was mentioned earlier, that technical assistance that's needed. Yes, let's talk about, the administrative burden. Let's talk about what needs to happen. But how are they operationalizing that? Are we going to come up with a standard system that counties and providers can use? Members also suggested being really clear about what you mean when you set accountability, because we can talk about processes and being clear about reports and this and that, but their focus on accountability is around outcome data that's specified. So for example, specific client-focused outcomes including reduced hospitalizations, measuring that, continuity of care, and symptom reduction. These are the things that are going to make a difference in how providers provide care to folks on the ground. We were also asked to comment very quickly on ACT and FACT and the fidelity and our thoughts about that. My little quote here is more time, more money, definitely. There were lots of comments, as you can see, just a couple here, around the impact of payment reform with the loss of reimbursement for travel time on the fidelity of ACT and FACT model. So with the requirements of the model comes a requirement for in-community support. There's, as you can see on the slide, folks are saying the FACT model and the ACT model requires 80% time in the community. It requires 4 or more contacts for 2 hours or more per client and a 10-to-1 staff ratio. What does all that speak to? We have to look what's under that. Transportation, 80% time in the community, you have to get there. The rates that are set up with counties need to account for the time for providers to get back and forth. Earlier this week, I had a provider in Humboldt County that said they're serving most of the county, yet they're not sure if they're going to be able to continue their operations because they cannot get reimbursed now for travel time. And while we know that that isn't necessarily a part of the modernization proposal, it is linked. So when you're saying there needs to be fidelity to the ACT and FACT models, we also need to take into consideration that there's this 80% time requirement, and how does that impact providers as they're trying to do the work that they need to do? Are they going to be able to do that? Is that creating an increased burden and stress? I don't think the intention is to, but we have to make sure that we're looking at all of the different factors at play at the ground level. Also, there needs to be a focus on fidelity, and we're hearing that. However, some may say, and some have said to me, that that's actually counter to the FSP model, that the FSP model was created to be a whatever it takes, and that there is an inherent flexibility in that, and that an over focus on the details of the fidelity to these models may have unintended consequences. And so we have to pay attention to that. It's a really fine balance there that has to be achieved, but it's necessary. And then also a general acknowledgement was shared around this work has already been done and is being done well. And it can lead, if there's too much focus there, it can lead to increased administrative burden. And that's something that we've heard already today when we're talking about paperwork reduction and all the other requirements. And we have to be clear that this is happening at a time when providers are overwhelmed, incredibly overwhelmed with the deluge of CalAIM, CareCord, and now the modernization. We cannot look at this piecemeal. We cannot look at this under a microscope. We have to look at it wholly as we look at the system and what's happening to our providers. We could focus in on one area and perfect that, but if they're also simultaneously being impacted by everything else that's happening right now, today in the system for them, it's going to be potentially detrimental, not just to them, but most importantly to the clients they served. We will, of course, continue to support, the administration in discussions about what needs to happen. But I'll share a little bit more here about Act and Fact Fidelity. Again, with the administration burden, you'll see here, people are saying, it's already what we do in FSP, right? So how do we figure out how to stay close to that fidelity without creating more burden, as mentioned already, paperwork, audits, et cetera? And I think that there has to be a moment where we step back and say, these folks have been doing this work for 20 years and been doing it really well. So I think that the focus should really be on lifting up the good models, the things that are working in the community, and building off of that and helping to promote that. There's not perfection in the system. There's not perfection in how providers are doing the work. But if we can focus on what's good and promote that, I think that's a step forward. We'll continue sharing concerns. We will continue supporting areas of the proposal that we believe are really on target to supporting providers, county partners, and most important, the clients. But the piecemeal focus on these areas is very problematic. So we hope that as you all continue to think about how the system is built out, that we're looking at all the various supports in the system that need to come into play and not just individual components. So I believe I've hit my 5 minutes, and I will pass it on to the next presenter. Thank you.
Thank you.
Good morning, Commissioners. I too would like to thank you for inviting me to join in this really important conversation. My name is Jolie Onodera. I'm the legislative advocate for the California State Association of Counties, or CSAC, representing all 58 counties across the state. So I was asked to focus on the proposed dedicated funding amount of 30% for housing interventions. So I will try to do that, provide both maybe overarching comments as well as a few specific examples. But I'd first like to start off by saying that counties do broadly agree with the governor's intent to enhance, the changes to the methodology of the MHSA. Since 2020, the CSAC policy platform has called for reforms to MHSA, and specifically our CSAC Board of Directors did approve a set of county priorities that supported changes, including revisions to the MHSA funding silos that would allow for greater funding flexibility tied to outcomes, as well as the addition of SUD, as Dr. Eisen so eloquently was discussing. With that being said, counties do believe that there are ways that the proposal can be strengthened, and we look forward to further engagement with the legislature and the administration, as the proposal continues to move forward. We believe that increasing county flexibilities is very key, as well as adding some fiscal protections, just given how volatile that the MHSA funding source is. And I know the LAO is going to speak to that a little bit later. Added flexibility, in particular for small counties, we think is critical to meet the unique needs, of their communities and better realize the opportunities that we do think can be afforded through these modernization changes. We also think that flexibility and fiscal protections will be important in recognition that the proposal doesn't include any new funding. However, it does expand the target population to include those with substance use disorders, as well as does require some new and enhanced reporting and planning processes. Lastly, we also feel that narrowing what now we feel is a very complex proposal would be very helpful. One, to just clarify, what is being put before the voters versus some of the other proposals that are currently in the bill that don't require voter approval and actually would become law upon the governor's signature of SB 326. And we also think that those additional proposals would be helpful to afford, a more robust discussion and vetting through the full legislative process. So with respect to the 30% on housing, based on my conversations with several different counties who've completed some initial analysis, this provision is going to, have varying impacts across counties, which is no surprise given how diverse, counties are, not only in size and geography, but in their provider networks, the housing availability, and the specific needs of each community. For some counties, in the absence of additional flexibilities being added to the proposal, this is going to be challenging for them to meet, and potentially at the expense of other services that are currently being provided. Would add that the subcategory restriction to an additional 50% for the chronically homeless, coupled with the additional component requirements in the proposal, will add some additional challenges as well to potentially, ensuring the stable provision of current programs and services. I think at a high level, just generally speaking, meeting that 30% requirement, we feel, is anticipated to result in some shifts away from the provision of existing core outpatient services and crisis services, and additionally, funding for prevention and early intervention programs that are currently being contracted with our community-based organizations. Further, we think that counties currently do leverage a significant amount of MHSA funding to draw down federal funds through Medi-Cal, and that diverting 30% of funds for non-medical billable services such as housing, that this federal match will be lost. And we do anticipate that much of the funding lost under the BHSA restructuring will be services again, including core outpatient, crisis, and recovery supporting services. To be maybe helpful with a few county-specific examples, I'll start with the large, in Los Angeles County. They've indicated that the proposal currently doesn't account for the large amount of funding that they utilize outside of MHSA to meet, some of their housing needs. And they've anticipated that the proposed categorical funding allocation would reduce funds that they currently use for mental health outpatient services, crisis and urgent care services, outreach services, and non-FSP homeless services by about 71% from what they've done in 22-23. In some of our more medium-sized counties, some of the most significant impacts due to that shift that I've been communicated would be a reduction in contracted community programs for prevention and early intervention, and a reduction that would be used now to cover the housing and homelessness-related services in that category. And then maybe just to wrap up, for our smallest counties, including our Eastern Sierra counties such as Alpine, Inyo, Mono, Plymouth, Sierra, and Modoc, we think in some cases that 30% just won't be possible to be met. And we're still in the process of getting more details from the small counties. But that being said, I think in summary, I really do think added flexibilities would be very helpful in order for our counties to be able to successfully implement some of these policies and the proposal. Thank you.
Thank you, Jolie. Thank you, Vitka, Leandra, Jolie. We are going to move on to our next group of panelists, and commissioners will come back if you could just hold your questions till then, just so we can get through the panelists. So at this time, I would like to invite Chris Stoner-Mertz, CEO of the California Alliance of Child and Family Services, and Andrea Wagner, Interim Executive Director of the California Association of Mental Health Peer-Run Organizations, who we have both asked to discuss the proposed dedicated local funding for population-based prevention and early intervention. Thank you for being here. Chris, if we could begin with you, please.
Thank you so much, Commissioner. I'm Chris Stoner-Mertz. I'm the CEO of the California Alliance of Child and Family Services, and I represent over 160 nonprofit organizations nationally accredited who serve children, youth, and families across many different public systems, from child welfare to juvenile justice to behavioral health to education. They are providing services across the state in 58 counties. And I think I also have a PowerPoint. Yes? That should be coming up momentarily.
Thank you.
The governor's attention to California's homeless crisis is laudable. We know that this issue is impacting communities across the state, and solutions are needed to address the crisis. We very much appreciate the Commission's attention to this topic and the thorough analysis that you've provided. The Commission's expressed support of prevention and early intervention services for children and youth is well established through your important initiatives that you've led, like the Mental Health Student Services Act, Youth Drop-In Centers, Early Psychosis Program, and we really applaud the recommendations that you've put together. Additionally, we support the focus and the allowance for substance use disorders to be addressed through the governor's proposal. We are concerned, of course, as many others have said, that adding services that are expected to be provided without additional funding to support those services is problematic. But we also know how critical it is to address substance use issues early, particularly in adolescence. Adolescence is generally regarded as the critical period for the initiation of alcohol abuse. There's considerable evidence that substance use among youth is widespread, and recent estimates indicate that the majority, 74% of substance use abusers admitted in treatment centers began substance use at the age of 17 or younger. That said, we are concerned that we're looking at addressing additional behavioral health needs without additional resources committed to the overall funding pot. Finally, we are wholeheartedly supportive of the additional accountability included in the Act. Our public behavioral health system needs to be more outcomes-driven rather than simply reporting on what services have been provided. While we, as I say, we applaud these elements, we are concerned about the impact to services for children, youth, and families, and my remarks today are primarily focused on that issue. Most critically, the reduction of articulated funding for prevention services, as well as losing some of the requirements that currently exist in regulation, that at least 51% of those prevention funds are used to support children and youth services. If you can go to the next slide. Oh, thank you. I'm in charge. Uh-oh, watch out. As is clear on this first slide, outlining the overall distribution of funds, the amount set aside for prevention goes from 19 to 5%, although I know that there is discussion about the flexibilities available to the counties. The reality is that we have a very visible homeless problem in this state. Children and youth are not visible in the way that a homeless adult is. And when you are a politician at the local level, you have to focus on that visible issue. So we are concerned that children and youth are going to get lost in that without some sort of clear set aside. The LAO report, which I'm sure they'll be talking about, we'll be talking about, recently outlines the clear loss of funding available for prevention services, and as Jolie mentioned as well, a number of current CSS and PEI programs that make up the majority of current spending that would fit within the new BHSS category will likely see reductions. As a state, we don't have a good track record of taking care of the behavioral health needs of our most vulnerable children and youth. Our auditor's reports from 2018 and in 2020 both indicate the lack of attention and investment to preventative Medi-Cal services for children in the state. We've strongly supported the work of the administration happening through the CYBHI, CalAIM, and other reforms. We are very supportive of the work that's happening there and have been very involved as stakeholders in work groups, et cetera. We do continue to be concerned, though, that we are going to lose something for children and youth in this reform if we do not clearly articulate how we're going to address and ensure that some of this funding goes to children and youth. We did a survey, as Leander did, with our member organizations that provide services through MHSA-funded programs. This slide gives you a small snapshot of those programs. The vast majority of those programs and services are funded through the current CSS and PEI funding buckets. This next slide highlights the populations served. As you can see, there's a wide range of ages served across our member organizations. And while this picture does not show the details of these programs, many of these programs are designed to be culturally specific, meeting the language needs that are so diverse across the state, as well as special populations such as LGBTQ youth. This slide gives you an idea of some of the types of services that are being provided by our member organizations as well. Family resource centers, early childhood mental health consultation, outreach programs, parent partners and peer work, non-traditional services for transition age youth. These programs are not currently funded under Medi-Cal and other behavioral health resources, and these are the very programs that we are talking about being at risk. They're programs that identify children's behavioral health needs early and help families get the resources they need before their child requires crisis intervention at higher costs and longer-term interventions. Most of you know that former foster youth make up 25% of today's homeless population. Without access to some of the very specific programs that MHSA funds that provide non-traditional services to foster youth, like family finding programs in San Bernardino County, or a pre- and post-adoption service program in Placer County, or a youth-defined and designed mental health support program for youth who are in transitional housing programs in Santa Clara County, we're going to see this number grow. To Vitka's point, foster youth also move between counties, as do other populations. And the challenge of moving from one county that's providing a particular type of service under the BHSA to another county that's doing something different is going to have a huge impact on youth that need that continuity of care across the state. Our Children's Coalition received several questions regarding our concerns from the administration and the legislature, and I've outlined some of the responses on these next couple of slides. I won't read all the way through them, but as I've mentioned, we are concerned about, as it currently is presented, that SB 326 allows counties to choose how they spend their categorical funding, giving them the option not to spend anything on children and youth. And again, the public and visible issues that our state is facing right now are homeless populations. And so we are concerned about the invisibility of those programs for children and youth. Right now, in terms of how much funding for children and youth is at risk, we estimate somewhere between $700 million and $1 billion is currently falling under the category of prevention and early intervention, community supports and services, and full service partnerships that are benefiting children and youth. So the big question, and I know there's been a lot of conversation about this today, and so much is in the details, but to the question of, aren't some of these other investments going to take care of kids? The short answer really is no. There is a lot that the governor and the administration are doing for children and youth, and we really do applaud that, and we are engaged in it and supportive of it. But there are places where there are still gaps. And if Medi-Cal, Medicaid is the bricks, MHSA, at least for children and youth, is the mortar. And a house with just bricks is going to fall apart. We've got to have the kind of flexibility that currently exists under the MHSA to be able to provide those additional supports and peer support services, youth advocates, and other types of supports that can help youth get what they need as they define it. Let me give you a couple of examples of this. The fee schedule, which is part of the CYBHI, again, supportive that we're moving in this direction of helping schools get mental health services, behavioral health services to students. That is going to be a voluntary program. So schools will get to decide, is that something they're going to utilize? That doesn't result in all children getting the services under that new fee schedule. Again, we applaud the work on EBPs and community-defined practices and the funding that's coming down for that. But again, some of that is one time. We do not have any clear assurance that Medicaid will follow to support those programs. Let me just skip to my closing because I know I'm getting probably past my time. We hope that you support recommendations that maintain a set-aside that prioritizes services for children and youth, as well as encourage the legislature and the administration to identify other pathways to funding for housing. We've all agreed it is a #1 priority. Other potential funding opportunities can be identified that do not redirect the available resources that mental health plans need for critical services, especially with the addition of substance use services being added to the service array. I want to thank the Commission for its excellent analysis and concerns raised for the discussion with the administration and the legislature. In addition to the concerns I've outlined, we strongly agree with the Commission's emphasis on the essential need for training in TA. The complexity of California's behavioral health funding is like no other state in the nation. And providing those with decision-making authority locally with the tools for planning, implementation, and ongoing TA is critical. And then finally, I just want to really uplift the comments of Commissioner Carnival. I think we are moving too fast, and with all of the other changes that are happening in our system, we have literally just begun payment reform in July. And nonprofit organizations aren't sure they're going to make it through this process, particularly the smaller ones. So we need to think that this is going to go to the ballot March 2024 without really embracing a planning process to ensure that we're going to get the needs of all these populations taken care of is really quite frightening for some of us. So we hope that you will continue to ask the questions that you're asking, to have the discussion that you're having. And again, we really feel strongly that we have to set aside some funding to support children and youth through this process. Thank you.
Thank you, Chris.
I do. Yeah, it's coming up. Hi, everyone. Thank you, commissioners, for having me here today. As was said, I'm Andrea Wagner. I'm the executive director for CAMPRO, the California Association of Mental Health Peer-Run Organizations. And I'm also the vice chair of the Butte County Behavioral Health Advisory Board and do a lot of local advocacy as well as a former county crisis employee. I thought about how to present today, and I thought, I'm here as the sole peer support person on the panel, and there is no way that I could represent the thousands of peers and the dozens of agencies that I work with on a regular basis, and that I would fail. So I've chosen, instead of bringing you data, I'm bringing you qualitative data, and I'm appealing to your heart today as far as how this affects us. I do have a PowerPoint, but okay. I'll just say that what I want to discuss today, and I'm trying to read so that I stay within my 7 minutes, is that I want to talk about how prevention and early intervention and innovation are essential to the Mental Health Services Act, an essential piece, I want to talk about the consumer priorities that we've gathered over the last 3 years as a grantee for the MHS OAC stakeholder program. And then I also want to just wrap up with our biggest concerns in this proposal. So I'm going to wait for the slides because I really think it illustrates. Is it going? Okay, great. All right, so I have a lot of pictures because, as I said, I really want to humanize this and show you some of the faces that are going to be affected directly by these changes, because I think that gets lost in all the rhetoric and all the legislative meetings. So that's my focus here today. Here are directly some of the people that are going to be impacted. You know, as I said, prevention and early intervention and innovation are essential pieces of Mental Health Services Act. In fact, they're the reason I'm here today. I was saved by an innovation program that no longer exists in our county because the county couldn't sustain it. But I digress. So I will stick to my script. I will say, so Campro, we want to also think back and give respect to the leaders who fought to develop the mental health system that we have today that is led by consumer and community-driven focus. Our founding director, Sally Zinman, was one of the fierce advocates who persistently organized, rallied, and fought for the passage of the Mental Health Services Act. It took over a decade of advocacy and community organization just to pass the Prop 63. And that included the voices of leaders from the peer, the Black, Indigenous persons of color, LGBTQIA+ communities, and others were included in the drafting of the MHSA. And their input was integral in shaping its intent and structure. And when it was passed, our peer community celebrated because we saw it as a win towards system transformation and a better mental health system. It aligns with the original values and intent, nothing about us without us, freedom of choice and self-determination, and uplifting the voices of mental health peers, BIPOC communities, and LGBTQIA+ communities, and others. PEI and innovation services do things differently. They include community-defined evidence practices. They are about choice, community, creativity, saving lives before they get to that crisis point. So as I said, we are a contractor with the MHS OAC for the stakeholder grant for adult consumers. And we are rounding out the year 3 of that for the Lived Experience Advocacy and Diversity Program. Over the 3 years, we've had 65 listening sessions, 20 county summits, and 3 statewide conferences. The most recent just wrapped up. We had over 600 people between online and in person here in Sacramento. In the process of that, we talked straight face-to-face to over 2,657 people. These are just some of the faces of the people that were involved. And I'll note that in the middle there, we have a picture from Manzanita Services out in Mendocino County. We just found out that the 15-year-old peer program dissolved January of this year, and that is not new. We've seen many peer-run community drop-in centers closing, and that's a trend that we're seeing. We reached all 5 regions, multiple ages, various socioeconomic and education levels, rural and urban, multiple genders, multiple religions, multiple languages. We had listening sessions in a variety of languages, and we reached many veterans as well. So out of that came priorities. Now I have 10 priorities that I'm going to talk about. They're in no particular order because depending on where you are in the state and what your population is, those priorities are going to shift slightly, and we have all the data. But these are the top 10 that came up across the board over the last 3 years. So the first 5, and these arguably all fit under prevention and early intervention and innovation. So the first is community. The word community came up especially in rural communities, but also community-defined spaces, places where people can help each other and feel safe with no pressure to conform. Resources, education, and outreach. People wanted help to know where the resources are, and permission and support to educate each other, to educate law enforcement, to educate families, and so on. They also brought up a lot about access to services, and that came in many forms. One of those is overcoming the barriers of having to have Medi-Cal or other insurances. It was also about location, having services close to where they live so they don't have to go across town and then across town again just to get the help they need. They wanted transportation support. They wanted childcare to be able to, go to services. Just an easier entry to get into services and care. They wanted cultural humility and representation, people who look like them and accept and understand them for where they are and accept their beliefs and their methods of healing. They wanted housing supports and not just roofs over their head. They talked about predatory landlords, the high cost of living, having safe neighborhoods, safe buildings to live in, and streets they could walk down that weren't just destroyed by other means. They also talked about eliminating stigma, being okay with being not okay, basic needs, showers, food, and clothing, a community that helps them survive and thrive with dignity, not just housing, but respect for the human being. Crisis and law enforcement education and response, educating law enforcement about mental health, but also having a non-law enforcement peer response to mental health crises. They talked about increasing services, having services, period. In some of the communities we talked in, there was just absolutely no behavioral health or mental health services available. They wanted peer support and they wanted peer respites. They wanted voluntary community services. And finally, they talked often in all the communities about how to take care of their youth and their elders. This is just one quote of many that we've gathered. This was in Sacramento County here locally in 2022. It says, "I think the system is infected with this idea that only professionals can build a fate. And when there's a lot of people that are not professionals that can help." So over the last few months and years, CAMPRO has organized and advocated against the continued efforts from the administration and state legislators to pass policy to dismantle and restructure the MHSA. Some of our biggest concerns are here. So first of all, reducing or eliminating PEI funds, diverting them. Programs funded through prevention and early intervention, as you've heard across the board today, and innovation are what makes MHSA different. It's not the status quo, and that's what makes it special. If we take that away, how is it any different from anything else in our mental health system? These programs allow counties to fund culturally relevant and community-defined spaces and practices. So diverting funding will inevitably kill many of these irreplaceable services. Bottom line, it will. And second, having MHSA dollars tied to only or mostly Medi-Cal billable services comes with strings attached. Medi-Cal billing and being site certified is cumbersome, it's intrusive, and often it's not always wanted or needed to do the job that these services do. And so organizations that offer services to people through peer support and community services that meet people where they're at without barriers of insurance and bureaucracy, they'll be pushed out of MHSA funding altogether. This includes many of, I believe it's 64 peer-run organizations that Rachel spoke about earlier that were funded through the Behavioral Health Workforce Development Fund with Department of Healthcare Services that cannot get Medi-Cal certified because the counties will not open up those contracts. And many community centers, wellness centers, drop-in services, and others are going to be hit hard by this and pushed out of MHSA funding. And third, we're very concerned about the reduction or elimination or changes to the community planning process. We think community planning process is essential. We advocate daily for the voice of peers and consumers. When it is done as intended, it gathers the voices of consumers and the larger community to identify the needs of that specific county. It's a crucial piece. And essentially, we are concerned that all stakeholders, not just consumers and peers, but all stakeholders are going to lose their voice in this planning process. So finally, I will just say that I think, this isn't modernization, as has been said. I feel like it's really just taking away the core values and the guiding principles of the Mental Health Services Act. And this is an MHSA modernization. It's essentially eliminating what makes MHSA special and different. And then I will just say my short list of what I would like to see is at minimum slowdown, listen to the people. You know, I've given you just a sample of the data that we've collected, but there's so much more to be collected. And I would love to see an analysis of the implementation before we say yes to something that could potentially destroy and eliminate services that our community desperately wants and desperately needs. Thank you.
Thank you, Andrea. Thank you, Chris. At this time, we will hear from our final panelist from the Legislative Analyst Office, Ryan Miller, Principal Fiscal and Policy Analyst, and Will Owens, Fiscal and Policy Analyst. I'm good. Okay. The commission has requested that Ryan discuss the proposal to lower the cap on allowable county reserves on MHSA revenues, and Will to discuss the proposed changes to the commission's role and restructuring of the MHSA funding categories. Thank you both for being here. We will start with Ryan.
Ryan Miller from the LAO. As you might be aware, we're the nonpartisan fiscal advisor to the legislature. So really a lot of the bulk of our work is analyzing governor's proposals and giving the legislature our recommendations on those proposals. We released a series of posts a couple weeks ago that initially look at the governor's proposal to change the MHSA. We're planning future work in the series, including looking at the bond bill and potentially some additional work. So stay tuned for that. I'll first discuss the post that looks at the revenue volatility. Now, many of you probably are familiar with a lot of the state budget problems that the state had in the past. Really over a decade, beginning in the 2000s, where the state was really struggling to right-size its budget. And that really originated with the huge run-up in revenues that the state had during the tech boom, and then the kind of big cliff that occurred in the dot-com bust. And as volatile as the state's revenues were, and as big as the challenges as those posed to the legislature and governor at the time, the MHSA millionaire's tax is far more volatile than state general fund revenue. We estimate that it's 3 times as volatile. And we think that this poses really critical challenges for counties in managing these funds. And so, you know, in this context, we assessed the governor's proposal to actually reduce the amount of reserves that counties are allowed to keep to protect against this volatility. I think one other perspective to offer before I jump into that, whereas in general, you know, the income tax, the sales tax, the major taxes that fund government services in California, they almost always grow when the economy is good, and then they will decline when the economy is in recession. MHSA revenue actually declined year over year in 8 out of 15 years that we looked at. Including in 2015-16, which was right in the middle of a solid economic expansion, where the revenue declined 18% year over year. So, you know, what we did initially was to look at this historical revenue performance and try to come up with what we thought was like a reasonable target. You know, and because revenue from the MHSA can drop substantially even in good times, we thought that a good target would be for revenue to be for the reserves to be almost certain to cover up to a 20% revenue decline like we've seen in good times, and then very likely to cover a 30% decline. And so we concluded that we think that the reserves actually currently are too low. You may be aware the current reserve cap is equal to 33% of the CSS category. We think that it probably should be about 55% of the CSS category to give counties reasonable protection against this volatility. And so, therefore, we would say that the governor's proposal would move the reserves in the wrong direction. As we looked at this issue, we also were looking at the rules governing when counties can put money into their reserves, when they can withdraw them. And in general, we think that the counties probably should have more flexibility in managing their revenues and reserves. For example, we don't think it really makes a lot of sense to both have a cap on the maximum allowable reserves, but then also cap the annual amount that they could deposit in reserves, especially since when revenues are surging, it's really kind of the ideal time to put a lot of money aside so that those reserves can be used to protect programs against cuts in the future. And finally, we're recommending that the legislature, if the legislature agrees that this proposal should move forward and be presented to the voters, we think it's an opportunity to revisit the revenue source for the MHSA. So we're recommending that the legislature actually change the revenue source, and we identified a number of different options. But one I'll outline here that we think has particular appeal. We looked at how much overall personal income tax revenue would have had to have been raised in the past to raise an equivalent amount of what the millionaire's tax has raised. So I think that, the concept is if you were to instead deposit the millionaire's tax into the state general fund and then take 2.3% of the personal income tax and move it to the MHSA, counties would have a far more stable revenue source. Specifically, volatility would be about 2/3 lower. Counties would still continue to see strong growth from that revenue. And this would come at a pretty small trade-off, we think, to the state of kind of a small marginal increase in state revenue volatility. And if the legislature agrees with the governor that reserve caps should be lower, we think that by making a change like this, that a lower reserve cap actually could be supported without imposing unnecessary fiscal risk onto counties. So I'll turn it over to Will.
Yes, Will Owens with the LAO. So I think Ryan's analysis on the revenue provides some really important context to some of the underlying kind of structure of the MHSA funding source as it is now. And so I'll talk briefly about the analysis we did on the shift in categories for the MHSA and kind of some of our key takeaways of that. So in the interest of time, I'll just kind of jump right into that, and if I'd be happy to answer any questions on the specifics of our analysis, as well as how we kind of came to the numbers, how we kind of evaluated that. And there are some limitations to that as well. And I think that speaks to our first point is that in general, we find the administration's justification for this shift to be incomplete. There are a number of concerns that we've raised before the legislature in terms of what will the consequences of this shift be. And there's a lot of uncertainty when it comes to what services currently may have to be shifted or potentially lost depending on how the proposal goes forward. So generally, we find that there is a shift in focus towards FSPs and housing interventions, and then this creates an issue where currently, based on our analysis, more funding would need to be directed to FSPs and housing. And while those may be policy goals that the administration and the legislature may wish to pursue, it would potentially come at a cost of having services that are currently would fit under the BHSS bucket be shifted away and redirected away from that. Generally, we find those services to be outpatient services, crisis intervention, wellness centers, outreach, where there is an overprescription that would be in this BHSS bucket. That being said, there's a lot of uncertainty how counties are going to react, what areas counties will prioritize, and that kind of leads to the next point that generally we find that there will be a loss of county flexibility in terms of how these funds could be used. We find generally that FSP and housing interventions, again, are fairly prescriptive in their use, and the BHSS category while has a decent amount of county flexibility, it's less funding available for more services, in particular with the majority of that funding need to be set aside for early intervention, and then the remaining funding hosting everything from outpatient to the reserve requirements, to workforce, to education and training. There's just a lot of services that are currently being funded or would be funded through the BHSS bucket that it's unclear what would happen. And the last point I'll make here is, and this will kind of tie into the analysis we did of the shift in the commission's responsibilities, is that we generally find that the proposal shifts kind of the decision-making and priority setting away from counties, as well as away from the commission, and into the administration. Again, this is through the kind of more prescriptive nature of the categories as proposed, and as I'll discuss now, kind of the shifting of the commission's authorities and responsibilities. So in our other analysis, we looked at kind of the shift in how the proposal changes the role of the commission. So I'm sure you're well aware that the original proposal included shifting the commission primarily under the Health and Human Services Agency, as well as changing the structure of the governance of the commission. Since the original proposal and the language has come out, that shift has been reverted, and with some exceptions, the governance and structure of the commission largely remains the same. However, we do find that a lot of the commission's roles and responsibilities, particularly with their general oversight role, as well as the setting of priorities for prevention and early intervention, as well as innovation programs, to be either removed or consolidated within DHCS. So again, while the general structure of the commission remains the same, we have found that the commission's ability to act as an independent oversight entity would very much be hampered by the loss in its regulatory and priority setting authority under the proposal. While it would largely remain outside of the current administrative structure and retain not only its independence, losing that independent authority and rulemaking and decision-making ability, we find could generally impact its ability to act and operate independently. So with that, happy to answer any questions, and just want to take the opportunity to thank you all for having us here.
Thank you, Ryan. Thank you, Will. So at this time, commissioners, and questions or comments to our panelists, please. Please, Commissioner Carnevale.
Everyone was excellent. I appreciate all the input. Ms. Wagner, you depicted what seemed like a grim outcome for the peer support system. Is it your opinion that if this plan is enacted, teen suicide will go down or up?
Well, I can't see the supports being there like they are now, so I imagine it would go up.
So we find ourselves in a position of solving homelessness, but driving teen suicide up. Where have we gotten to the point where California is making these decisions? Thank you.
I wanted to clarify Jolie's comment. Thank you for speaking. I think that's kind of the missing piece, but what the counties were saying, because it's been kind of silent. There's been some backdoor conversations, but nothing like on public record. So I want to applaud you for stepping out. You noted in your presentation that, I don't know if it was like 70% of services. Can you just expand on that, and then I'll get to my next point?
Oh, it was for LA County specifically?
I think it was LA, I mean, which I do, I'm in LA, so.
Right, yeah, with the proposed shift, and I think it's particularly because Los Angeles County, which is, not like all counties, they do have Measure H, which provides them with additional monies for our housing and homelessness services. In the absence of, being able, with the rigidity of the 30%, which currently is being used for other services, it would result in a 71% reduction in their outpatient and crisis services in order to meet the 30%, through the use of MHSA, since currently they're able to use, other dollars for some of those services.
So would you say that we could see more like crisis, more people, if you can't get crisis services, then that could result in death, like worse outcomes than?
Well, in the absence of services, the outcomes would probably be difficult. I think what we're looking for really is just a request for additional flexibilities to account for, all the differences that occur across our state and the different counties with different situations, to be able to make sure that we can continue to provide the services we think are necessary.
And did you say potentially that peer services would also be impacted, or wellness centers, or?
I think that was a different panelist,
Okay.
but, definitely outpatient. Was it
Well, yeah,
crisis?
outpatient includes
Yeah,
peer support.
right.
Appreciate that. And then I just want to shout out to the Legislative Analyst Office for your non-biased analysis. It was very, I read it when it first came out. I thought it was very thorough, and you guys put a lot of effort and thought into revenue structure, and then also your analysis of the funding buckets and how the services. Would you say, and I heard it, but would you say, in short, services will be lost?
There's definitely a reprioritization of current MHSA, specifically MHSA expenditures towards FSPs and housing. And so I would hesitate to say exactly what services will or won't be lost, especially on a county by county basis. I think counties will have to make those decisions. But we just, based on the numbers, we would expect that services that are currently funded that would fit in that BHSS category would by necessity need to be redirected towards FSPs and housing. And so what that means county by county in terms of the specific types of services, there definitely would be a refocusing.
I have a lot of experience, and I've developed every aspect of the continuum of care as a technical writer, so I'm very familiar with the whole continuum of care. Would you say that this proposal shifts to really serving just the sickest people, because when you do the whole continuum, it's early intervention, PEI, wellness centers, all the way to IMDs. Is it a shift in how we're addressing behavioral health? We're going to just focus on housing, and we're going to focus on substance use, FSP, whatever it takes model?
So we haven't looked at, we unfortunately don't have access to the data that really lets us look at the fine-grained detail of the individuals who are being served. And so it's hard to say exactly, other than that they're currently, as is funded by MHSA, there would need to be a shift to include more MHSA funding for housing. And that includes, I think, it could include a fairly robust range of housing interventions, but housing nonetheless, and FSPs. And so when we look at the actual services that are being provided under that BHSS bucket, these are primarily outpatient services, wellness centers, crisis intervention. And I know, to your point, specifically on the PE&I bucket, we estimate that almost the entirety of that bucket would kind of be going towards that BHSS component, which is in fact the component that is overprescribed as proposed. So there would definitely be a redirection and focus there.
Thank you for your analysis, and really appreciate you.
Okay, thank you, Commissioner Chambers. Just out of respect for the administration, I do want to say this. They do have to depart at 12:45, so they had let us know before that. And so I just want to be really clear with that. Please, JC.
I just wanted to, given the comments by both our county colleagues and the LAO, just to remind people, under realignment and under Medicaid federal rules, the counties are actually obligated to continue to provide the whole continuum of services to people enrolled in Medi-Cal. And that includes all services that are specialty mental health and SUD services. They don't have an option of not providing those services. They are obligated to use both realignment dollars. Of course, some of the MHSA dollars today are used as a non-federal share for those services to draw down federal funds. I just wanted to ground us in the fact that there are other federal and state requirements for our county partners to continue to provide the obligation of all specialty mental health services and SUD services to individuals based on whatever the benefit that they've elected within their county. So I just wanted to ground us in that information and that requirement, because that is an entitlement. It's a federal entitlement, and that is a requirement both in state statute and in federal law. So I know that we're shifting some of the priorities to the comments and points. I just wanted to make sure that's not getting lost in regards to the continued obligation of our county partners. And Jolie's shaking her head, so she understands that. I just wanted to make sure we are shifting and we are hearing and listening to everything. I wrote extensive notes, so I just want to say that in regards to the shifts and the impacts that this could have, but it doesn't negate the county's obligation to continue to provide those services. So I just wanted to add that if I could. Thank you for
So that would only be for Medi-Cal recipients, right?
For that part that I'm speaking to, that is correct.
Because
And I
a
wanna
lot
be
of the
clear.
services that this covers, they're for people that are outside of that, particularly these wellness centers, drop-in centers,
Prevention
crisis.
services.
Yeah, so crisis is
Crisis
fully
is
covered
different.
in Medi-Cal, but for people not on Medi-Cal, to
But
your
not,
point.
for not on Medi-Cal too?
Yeah,
That's
and
good to know.
commercially insured
And on commercially
people.
insured, completely covered, yeah.
Yeah, absolutely. I just wanted to make one other comment, and just in case I don't get an option or a chance to. We really worked hard to try to actually make the community planning process more robust and more transparent and include more people. So I'd really like to have a better understanding of why there is a concern that that process, the way that we've proposed for it to change, is not positive or has some drawbacks, because that was just, and we can talk about it, Andrew. I just want to make sure that the public understands that it's absolutely the administration and the legislature's intent to actually make that process more robust. It's actually essential because of some of the changes that we're making. The community planning process is going to make some decisions about some of the conversations that we're having. So we don't have to have that conversation here, but I'd be very interested in anyone's recommendations on ways in which that could be strengthened, or what, I don't know what we did that might have been concerning that it might actually not have an effective community planning process. So
You didn't. Oh my God.
Thank you. I'm going to ask for Commissioner Rolette. Did you have your hand up?
I did, and I was going to make some brief comments, but want to be respectful of the time.
Please go ahead and make your comments, sir.
I wanted to underscore the points made by Chris and Vitka and certainly Leandra as it relates to housing and the availability of housing as it ameliorates a lot of the distress that the people that we're privileged to serve have, and that we do have a housing crisis that, again, while I certainly endorse everything that the administration is trying to do to resolve, I'm yet to enthusiastically endorse this plan and what it aims to do as it pertains to housing, and then what I described earlier as the deleterious potential effects on other services as we redirect resources to housing. I agree. Vitka said it very well. When people get housed, they do better. However, when you redirect resources, that does inevitably, especially given what the LAO just said, have a deleterious effect on what I think is services that are funded out of the CSS bucket.
Thank you, Commissioner Rolette. Please, Commissioner Bontrager.
I have a question for the LAO's office. You know, my understanding of MHSA this year, about a third of the funding would be about $1 billion statewide. So if we're talking about dedicating $1 billion per year for housing, is there oh, it is on, okay. Is there a way that we can increase the bond and accomplish those purposes without in perpetuity dedicating this funding towards housing, which is the issue of the day? I get that. But in perpetuity, it may not be. So is there another way to accomplish and achieve the aims of this without forever binding the hands of how we allocate funds through MHSA?
I can field that, Ryan Miller, LEO. So, I mean, I'd say that, like, technically, I don't think there's a reason why the bond authority couldn't be increased. I think that's something that could be considered. I think that one thing our office would provide as a perspective, however, would be that while generally speaking, it's reasonable to fund infrastructure, like behavioral health facilities over a 20, 30-year period with a bond because, they will be in service for a long time, and it's reasonable to expect future taxpayers to pay for those as well as current taxpayers. I think that something that would be different, say with services, would be that it would probably make more sense for the services to be funded on like an annual basis, like through the MHSA as it would be proposed with this 30% bucket. So, but again, going back to your original question, technically speaking, I think that the bond authority could be higher if that was something that the legislature and governor wanted to do.
Other questions? Comments?
I just want to, I'm really struck by Commissioner Carnavelli's point and question and then response from Andrea. I think that, again, we're all trying to solve, we're all trying to solve these issues. We're all here trying to figure it out, but there's definitely concerns. And, Stephanie, you asked about what is it that is why people are concerned about the community process. I think when things go fast, like it's happening right now, and like it happened with care courts, there's a trust that's then broken, right? We're hearing you say that, but we're also experiencing a rushing of what is really important. So being able to walk the talk in that process, yes, this process, sorry, thank you. This process where, and I'm not trying to, you're, not the, I know, you've been really engaging us and JC too. So not you all, but you're getting this response because, of course, you're the representatives here, for the administration and the questions are, and the concerns are, this will impact our communities. Not saying that the changes around, more behavioral health and meeting the people's needs and addressing the homeless issues aren't something that we don't talk about, and that pulling funds from the federal government isn't something counties and providers and everyone isn't already trying to do. Definitely more capacity support around that is needed, but this is being rushed. And so how the emphasis in this that you're going to develop a community process of now, I think this is the time where we're saying, again, going to the March ballot, that's less than, a year away, and it's going to come up quick. So that's, I think, something that is hopefully can be rectified and looked at so that there is more conversation and more, again, I think we know we need more resources. We need more resources, not just from the federal government, but more support for MHSA. So, and you've probably heard of, adding an extra tax to the millionaires for this, so that, let's get more housing for the people we serve, but not reduce the services that so desperately everyone needs.
Thank you. I just want to acknowledge that was super helpful to clarify, and again, have heard that loud and clear that this process has not been working for people to provide adequate input, and that's a helpful clarification versus what is proposed in the statutory changes at the local level. But again, we still take a look at that level too, and that's important to us. And so if we didn't do a good job, or if there are improvements that need to be made so that that's a better process as well, very open to hearing about that.
Thank you. So I would say, for me, it's some of both. I think there's still more to do and more to discuss. So thank you for being here. And I want to go back to my original statement around the student mental health. I'm going to plug that in time I can. So I want to go back to that. And that it's still early. We're still, I think it was Jolie who said, who talked about the unintended consequences. And thank you, Leandra, for the slides. Getting those voices, getting those comments. There's things that we don't know. And I think it's important to keep spending more time on discovering more because we don't have all the answers. At minimum, I think if we were to allow for the legislature to be able to make changes without going back to the ballot, and that's at minimum. Because I'm thinking there's so much happening so quickly. We're about a year and a half away from this post-pandemic. Mental health service, the mental health needs of students, as I see them in my frame, and talking to other county office leaders, are just really popping up in ways that we had not, nor could we have predicted. And so I don't want to be tied down to having to go to ballot. This process can't take years, right? We've got children dying, and it can't be. And I appreciate what Commissioner Carnevale said. Yeah, I think the middle piece is missing. So how do we pause and just take some time? We will meet and discuss whenever you want to meet and discuss, because it's just too important for everybody in this room, including our community online. So with that, I want to respect your time. I know you need to leave. So we are going to take community comment. We are going to ask, we're going to need to make that 2 minutes for each community member to make comment, please. We are behind schedule. We appreciate your understanding of this. So with that, let me, okay, 1 moment, we will get that started. All right, thank you all for being here. Thank you for your time. We are going to have community input. We would love for you to hear that and stay with us, please, panelists, if you can. So, at this time, members of the public may request to make a public comment on the agenda, item 6, by clicking the raise hand button on your computer or the app, or if by calling in by phone, *9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Are there any public comments? Please raise your hand now, as the queue will be closing. And again, we ask that you please limit your comments to 2 minutes or less. Lester, please open the line for public comment on agenda item 6.
Madam Chair, we have 20 public comments and 3 additional comments if you'd like to take those as well.
Okay, let's go ahead and get started, Lester.
Okay.
And close it after the 3, please.
Yes. Hector, your line is open. Please go ahead.
Thank you. My name is Hector Ramirez. I'm an authentic primary stakeholder of the Los Angeles County Department of Mental Health, where I receive services, and I'm also a Medi-Cal member. So I really wanted to thank the presentation. It was very informative. I do think it's important to reform, if not the act, that the commission, or both, as a stakeholder of Los Angeles County, which provides services to almost 250,000 residents, many of which receive mental health services. We have seen during the pandemic that if something needs to be reformed, now that we're better, is the MHSA. Our County Department of Mental Health is significantly broken, particularly our Mental Health Services Act. The previous executive director that we had, while working very diligently, really disengaged our Latino and Hispanic population and our disabled population, our Native American and LGBTQIA2 community, particularly our transgender community. And we have had no really opportunity really to highlight the importance that this were some of the populations that originally were supposed to be served by the Mental Health Services Act, and it still hasn't happened. The lack of accountability and oversight of this commission really has been appropriate, but if you're going to use the cost benefit analysis, how much money we will lose if we don't do this, think about how much money we will lose if we don't act now. And since you don't provide that analysis, let me provide you with the status quo. The majority of our population right now who are struggling to get mental health services in LA County can't do it. Most of our peers are either on the streets, homeless, or in jail, because we have been able really to access and leverage what the mental health service was supposed to do. Lack of oversight and accountability by our county and our director at the time made it impossible for stakeholders to be able to advocate at the county level. And then we had an inability to be able to advocate at the state level of this commission because of issues with
Thank you.
advocacy and
Your 2
accountability.
minutes is up. Please
Thank
wrap
you.
up your comments. Thank you. Michelle, your line is open. Please go ahead.
Good afternoon, commissioners and members of the public. Michelle Cabrera with the County Behavioral Health Directors Association. And just want to thank the commission for a robust conversation today and align ourselves with the comments of CSAC. And also to say that we appreciate the legislative analyst proposal, as the County Behavioral Health Directors have been working to understand the potential impacts. We find that 60 to 80% drop in funding for those core outpatient crisis and recovery services due to the shifts in funding. And that, because most of those services are reimbursable under Medi-Cal, a significant loss of federal financial participation. So for every dollar lost there, equivalent of $2. As the LAO pointed out, counties don't have very anywhere else to go. Yes, they are required to fund Medi-Cal services or services to Medi-Cal beneficiaries as part of their entitlement responsibility. But today, the Mental Health Services Act accounts for a third provide those Medi-Cal services, and we are able to leverage approximately 1/2 as a source of non-federal share in Medi-Cal today. We urge the commissioners to consider how this will have devastating impacts on individuals' well-being and stability, particularly, again, with those outpatient and crisis services. We also appreciate the opportunity to have a discussion about volatility in the Mental Health Services Act, which is not proposed to be addressed through this proposal, but we believe is a real fundamental issue for us to grapple with if we are going to be looking. There are significant restrictions. In particular, I want to call out the definition of chronically homelessness. Thank you so much. We hope that we can move away from that federal definition. Thank you.
Diego, your line is open. Please go ahead.
Good afternoon, commissioners. My name is Diego Bravo, and I'm with Safe Passages, an Oakland-based nonprofit and member of the California Reducing Disparities Project. I just wanted to come on today briefly to talk about, to make public comment about the modernization plan, and in particular, the funding allocation guidelines. As you know, many of us in the community have some pretty big concerns on the modernization proposal as it stands, and wanted to address, shed some light on what we believe could be some pretty major limitations in the language. So first, probably the most pressing item here, we and 60 plus organizations throughout the state representing counties, communities, localities throughout California, like many others today, believe that it's imperative to preserve the current requirements for local funding of PEI and innovation components of the MHSA. The 5% cap on population-based prevention programs in the plan as it stands is simply just inadequate, for lack of a better term, and will lead to a complete deficit of population-based prevention work throughout the state. Programs that have been studied to work, that work effectively and efficiently, and are also proven to be very cost-effective. So when we break PEI up into these two categories, into planning and into early intervention, instead of creating a cohesive system of upstream behavioral health services, we're really just breaking these often life-saving and mission-critical programs down further, dramatically reducing funding for services that are designed to be implemented in historically underserved communities. And many of us in the behavioral health community believe that this could lead to some pretty wide sweeping effects in behavioral health in our neighborhoods, our communities, with our families, creating even more racial disparities in mental health and behavioral health in a state where that runs really deep. So I wanted to echo that point and emphasize how crucial these services are, and the weight these policy decisions have, as you all know. And two, keeping it brief, we believe that the innovation category of funding should remain.
Diego, your time is up. Please wrap up your comment.
Thank you.
Vera, your line is open. Please go ahead.
thank you so much to the commission and to the invited guests. The information was really helpful. I am a certified peer, California State Certified Peer Specialist who's worked in LA County for 12 years as a peer specialist in the field, and also the last 5 years as director of a peer-run program in a huge human services organization that had about 20 different divisions. And I'm also chair of the California Association of Peer Professionals, chair of the steering committee, and I sit on the California Behavioral Health Planning Council and currently chair the Workforce and Employment Committee. And I'm here today as a person with lived experience who this last weekend, last Friday night, had a panic attack, an anxiety attack that I thought would have me hospitalized for the first time in 20 years. And it scared me. And I would just like to say that I believe the MHSA needs an overhaul. But why not take the extra time needed to create a truly revolutionary system of care that other states will want to copy and emulate? I mean, we're Californians, right? So outside of very few exceptions, I still believe haste makes waste. And I believe we're probably all here, if I could use the term, be the change for our families, our fellow Californians. So why can't we just move together in a direction that'll lead us from strength to strength instead of potentially harming people with its missteps? Thank you very much.
Thank you. Isaiah, your line is open. Please go ahead.
Good afternoon, everyone. Thank you for everybody's patience. Thank you for the opportunity to speak. My name is Isaiah Gonzalez. I work as the Veteran Liaison at Life on Earth Art, which is a community partner with the Veteran Art Project. So we have received grant funding through what they've been given by the Commission. I am also a veteran myself. I served from 2015 to 2020, so I am of recent service, and I am someone who has been diagnosed with co-occurring substance abuse issues. I received mental health care through the VA, and that started while I was on active duty. I've been to rehab 35 days inpatient. I am so grateful for the depth and for the amount of expertise that is here in this Zoom room. I do want to advocate and vocalize for, as we continue to talk about substance abuse and behavioral health, that we ensure that we save space for cannabis patients and that we give them legitimacy and support, and that we continue to educate healthcare providers on the endocannabinoid system. I am also a member of the Veterans Action Council, and I will actually be on my way to the California State Fair here shortly to go speak on a veterans panel amongst the cannabis pavilion exhibition. And so I say it on behalf of my entire community that while veterans are very prominent in that discussion, that we need to save space for everybody who chooses to use it as a patient. And I just, I'm a little overwhelmed, but thank you guys. I'm gonna continue to get ready to go, but I mean that from the bottom of my heart, not just that, but as well, thank you for holding space for arts, for funding it, for ensuring that communities have ways to come together to create beautiful displays in support of activism. Engaging in those things in combination with utilizing cannabis have been the things that have personally saved my mental health.
Thank you, Isaiah. Your time is up. Please wrap up your comment.
Thank you.
Thank you. Stacy, your line is open. Please go ahead.
Good morning, commissioners and panelists. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I want to thank the commission for spending so much time on this most important issue. All the panelists were excellent, both knowledgeable and experienced. I only wish there had been a panelist to speak from the perspective primarily of BIPOC and/or LGBTQ communities, because there is no doubt in my mind they will bear the brunt of this large policy change. Underserved communities suffered most during COVID, both in terms of experiencing the ravages of the disease, the economic and other impacts, but also in the recovery and not recovering as quickly. They suffer most because of climate change and every other social problem, societal problem. However, just as we were not given a seat to provide from our perspective the situation and the solutions, I sincerely believe we will suffer most when these large policy changes are implemented. I do want to thank Andrea Wagner for bringing up the large concerns that overlap the consumer community and underserved racial, ethnic, and LGBTQ communities, especially in regards to PEI, the emphasis on Medi-Cal match, and the community planning process. I would like to support the comments of my colleague Diego Bravo in terms of PEI and innovations. This is REMCO's most serious concern because, again, we have limited bandwidth and we must depend on the others to lift up other concerns that are also important. I do appreciate that the administration and others more politically powerful than us seem to recognize the importance of community-defined evidence practices, or CDEPs, to BIPOC and LGBTQ communities.
Your time is up. If you could please wrap up your comment.
But the language of the bill does not provide the support for CDEPs. Thank you.
Steve, your line is open. Please go ahead.
Hi, this is Steve McNally from Orange County. I'm on a behavioral health advisory board. My comments are as an individual. Well, first, thanks for the member comments. I found them to be really good and open. And interestingly, not as open as maybe in a Department of Healthcare Services task force meeting. I think we can all agree there's problems all around. But I don't think what's clearly identified is why, if the mental health system is working so well that we can take $700 million out of it to fix another system or to help another system that's even more underfunded than mental health. Why don't we just figure out what is the total amount to fix each of the problems and then start to prioritize sort of Commissioner Carnevale's comments. And why don't we present this to the people? Once it gets on a proposition, it'll fix today's problem without flexibility for tomorrow's problem. And I'll make a pitch again. California Endowment, Sacramento, Oakland, and Los Angeles, why don't you invite the legislators and the panel, present the case? Because this seems to me to be headline chasing. And my comments are from being a family who's received tons of services. And one thing I learned was trust and relationships really help recovery. And California doesn't have trust at any level, from the state to the county, to the city, to the community. So please consider empowering the 40 million of us to help solve this problem. Because while Apple and Cisco gave 100 million in Santa Clara, we've yet to see more than 5 million in Orange County from Disney.
Could you please wrap up your comment?
Thank you. And please ask Stephanie, and who I respect a lot, just to view the public comments, because getting out of Sacramento gives you a different view of what's going on in California. Thank you.
Elizabeth, your line is open. Please go ahead.
Thank you for the opportunity to comment. My name is Elizabeth Osiguera, and I'm with the California Primary Care Association, who represents over 1,270 health centers and their 7.7 million patients. We appreciate and support the administration's goal to expand housing, but ask that this not be done to the detriment of PI and innovation services, which CBOs, including health centers, access in partnership with counties. We ask that the process be slowed down to allow for true stakeholder input so that we help to bake the idea in partnership with the administration. This would allow for more time to think creatively and how we can fund both services in the MHSA today and have those remain, and housing initiatives that the administration is hoping to move forward. Let's work to change the or in the current proposal and change it to an and so both things can be funded. Thank you.
Thank you. Jerry, your line is open. Please go ahead.
Hi there, Jerry Hall out of San Diego. Thank you once again. I'm speaking in support of transparency and accessible data in relation to BHSA evaluation, planning, and budgeting processes. And when I refer to data, I mean de-identified, ideally cross-tab data that is machine readable and made available on an open data portal. What's been tough to find as a stakeholder in San Diego County anyway is gap analysis or any kind of data that might be critical to the existing work we do. And I'm concerned that people are more interested in careers and political futures than they are the actual, the criticism. And I think the criticism is valuable. This data would give us insight on the challenges and inform potentially, rich solutions. It's also tough for stakeholders to provide feedback throughout the year when we aren't able to query or review or test the data. So I ask that we make a wide range of data available. We provide tools like Python, R, BI, Tableau, CCAN, tools to be able to let stakeholders query the data and then make reports or visualizations that they can use to support their hypothesis. And also in our annual plans and contracts and reports, we need to be mindful about detailing specific outcomes. And then when we get later reports, it's in the context of those outcomes so that we can see if we're meeting the numbers or not, and it'll help stakeholders make more informed contributions on the trade-off of spending money or adjusting the plans. Thank you.
Thank you. Tiffany, your line is open. Please go ahead.
Thank you. I'm an employee with Painted Brain, but today I'm going to be speaking to my own perspective. I've been in the mental health system for a long time, including in the early aughts. And if we can just go back in time for a moment, it was a really bleak picture. There wasn't a lot of service for people who needed just regular ongoing services, who had medi-medi. Therapy was extremely limited. Even though that was what I needed, it was limited to 5 visits. There weren't any peer-run services. There was, a lot of emphasis on what's wrong, a lot of clinical closures approaching 2008. And there was no room for dissent. If medications weren't working, well, that's just because you haven't been on them long enough. And now we have an emphasis on choice. We have widely available therapeutic options, peer-run services, a focus on what's strong, and and choice when it comes to medication, which has been so very beneficial for people. The changes that we're talking about could move people who are stable, who are receiving services that allow them to remain stable, progressing them towards crisis, progressing them towards homelessness and loss of employment, moving towards full psychiatric disability, and that there will be fewer opportunities for CSS innovations and PEI funded services for low-income individuals. So I would really encourage a deep look at how these services are going to change and what it's going to mean for people who might not be in crisis, might not be on the streets, but will end up there if we change too much too quickly. Thank you.
Thank you. Richard, your line is open. Please go ahead.
Hello, this is Richard Gallo from Santa Cruz, California. I am a volunteer Access Ambassador with Access California, a program of Cal Voices. I am extremely concerned with this fast-paced changes. It's obviously that's going to happen. A lot of this has to do basically to support 3 programs: CareCourt, CalAIM, Mental Health Services Modernization Act. It's dismantling the spirit of the MHSA and focus on other priorities, tapping on funding sources to use for other priorities. I have heard no mention of what's going to happen or where we are with the California Medi-Cal peer support certification. Where we are with that. CalMESA has invested 5,000 peer workers throughout California to be part of the workforce movement. Not one word from the agencies. Where are we with that? Is that going to be part of CareCorp? Is that going to be part of CalAIM? Is that going to be part of MHSA Modernization Act? The full service partnership needs to be 100% person with lived experience, since this is what the funding will be used. The Mental Health Services Oversight Commission has failed to transform our mental health system, especially with the SMI unhoused community throughout California, and not creating peer programs and services throughout California that it is in the act to provide within our community to help our own peers. What we need to do is educate the community to vote down this bond measure. What we need the Oversight Commission to do is hugely fund advocacy project, because this project is going to fail. It is
Thank you,
about
Richard.
meeting the
Your time is
needs
up. If you could please
of
wrap up your comment.
Governor Newsom. Thank you.
Thanks, Richard. Stephanie, your line is open. Please go ahead.
Hi, everyone. My name is Stephanie Ramos. I'm with California Association of Peer Professionals, as well as Cal Voices. On behalf of the association, I really want to, really talk about the importance and emphasis of peers. When the Mental Health Services Act began years ago, we had an influx of individuals with lived experience working in our system. And with this new legislation, there is a huge potential for that to change. If you look at what's currently going on, even outside of this, we're seeing big investments in community health workers and wellness coaches, where they're actually having their certification go through state departments rather than a JPA. And so we've seen a lot of preference for non-peer workers in a lot of ways throughout the system. And we're even seeing to the point where with CalAIM implementation, peers are starting to begin given billing quotas where they might have disciplinary action if we don't meet those quotas. And if you do, you get some extra PTO. And so we're already starting to see the impacts of these policy changes when we're not really incorporating the lived experience into those. I also want to remind people with housing, often we have housing developments that go up. A ton of money goes out to those developers, and counties often do not own that housing. And there is a limited contract period in which we need to provide that housing to our actual community members. And so thinking of long-term investments, how does this actually play out in the long run once those contracts are no longer in place? And where do we put people who will continue to need housing? And lastly, I would just on a personal note, my sibling does receive services through an FSP. And I will say that that service has been really instrumental in keeping her well over the years. But I want to remind people that, as we start to go in this direction of increasing FSPs, increasing clinical services, we're going back to focusing a lot on the medical model and medications. And medications don't work for everybody. Medications don't always suddenly bring someone back to what we want to call normal, where they can, meet all those outcomes that we want to see. We know it works for some and some for others. And so just to remind people that people need more than those, that medical model service. Thank you.
All right. Thank you. Claire, your line is open. Please go ahead.
Hi, good afternoon. My name is Claire Courtwright. I'm a peer and I am an attorney, and I've been really diving in and analyzing 326. And I would like to point out that the administration has not defined housing intervention in 326. We don't know what that actually means. And, the LAO is estimating that $800 million a year must be spent on housing interventions, half of that only on the chronically unhoused with a focus on encampments. And under 326, counties may no longer spend a housing dollar on someone unless they are meeting the federal definitions of chronically homeless, currently homeless, or at risk of homelessness. Right now, MHSA allows a housing dollar to be spent on anybody in the target population. So you are narrowing the population that can have housing money spent on them. And I'm concerned that that means someone who is not in that federal definition is getting left out and could actually lose housing. I mean, we've talked a lot about people losing services. I'm concerned somebody could lose housing. Second, while the administration has emphasized voluntary unlocked beds, that's language from the bond. That's from AB 531. None of that language is in the housing intervention section of SB 326. And SB 326 housing intervention sections are unrelated to the bond. They don't talk about each other. They're two different things. And I noticed that in the June PowerPoint from the administration, they gave an example of a use of housing intervention funds. And that was for a person, quote, placed in a residential treatment facility where there was no Medi-Cal funding to pay for the stay. The person only had Social Security supplemental income, and that couldn't pay for the stay. And there they said that the housing intervention money could be used as a patch to pay for that stay. So we know that including it in housing intervention is clinical treatment stays. That's not housing. So I'm seeing, $800 million. Basically.
Wrap up your comment.
I'm sorry. Okay, I'll cut it there. Thank you.
Thank you. Katie, your line is open. Please go ahead.
Yes, good afternoon, everybody. My name is Katie Sommerfeld, and I am a peer, and I also work at Campbro as office administrator, but my comments are my own. So there is a fear that this modernization proposal is going to fund Care Court, and that the new jobs that will be created are to support that, which so many of those providers that will be needed are against the whole system to begin with. So you can just imagine just what a detriment that will be to the workforce, especially the peer workforce. Inevitably, you will be taking away services for PEI and other outpatient services such as wellness centers, crisis, etc., that people who utilize those services to maintain their wellness will be at risk of suffering deeper in their mental health, as my fellow peer Tiffany highlighted. And I'm also curious, when are we going to see how peers will bill for services under Medi-Cal if it moves in this direction, especially if they're not state certified? It seems like non-certified peer jobs are going to be even more negatively impacted with this proposal. I realize peers are just one of the professions that could be impacted. And then we should look at how this will impact peers with decades of experience and the other racial ethnic demographics that are not represented with certification. And the future of peer support feels so uncertain and grim with this proposal. Thank you.
All right. Thank you. Melissa, your line is open. Please go ahead.
Thank you, Lester. Thank you, Commissioners and Lester. My name is Melissa Hanna. I'm the Executive Director of United Parents. I want to thank, this is a huge thank you to Chris, Leandra, and Andrea. I'm so thankful that you're here today to support and speak on behalf and speak on behalf of and lift the voice of our children, youth, families, and peers. I work for United Parents. We are a community-based organization that was formed over 30 years ago by parents, for parents who are raising children with mental health needs. Because of the partnership with and continued PEI funding from our county and the MHS-OAC, we have been able to provide beneficial peer, parent, partner support services in the communities we serve. Each year, we give more than 500 families the support they need to preserve their family unit, their safety, and their comfort. We give parents a break. We meet the families where they are with the services they need and trust with people who get them, who have walked this path and are now here to walk this path with them. Just last week, because of the services we provide, we helped prevent a 9-year-old from harming themselves by listening and supporting. We recently have been pushed to start billing Medi-Cal. In just this short time, I cannot begin to discuss all of the issues we have encountered as a small community-based organization. I still have not been able to come up for air. This Medi-Cal system feels like a fail-first system for CBOs. It is a round hole and we are a square peg. It has taken 30 years of working with the underserved and the unserved communities to form our beautifully formed square peg. The removal of the PEI funding will sand those beautifully formed curves down to fit a space that was not built with or for our families and our community-based organizations. Thank you.
Thanks, Melissa. Laurel, your line is open. Please go ahead. Laurel, you're still muted.
I'm sorry. Earlier, I tried to unmute and it would not let me. I have to, just a moment. So I'm Laurel Ben Hamida. Can you hear me now?
Yes, we can.
Okay. Laurel Ben Hamida from Muslim American Society Social Services Foundation in Sacramento and some statewide services and REMCO. I want to talk about the financial realities of PEI for reducing mental health disparities. First, there are not enough clinicians in California to meet present and future needs for early intervention clinical services for non-English speaking people in their native languages. There are not enough tested competent language interpreters in California to meet present and future needs for early intervention and later possibly clinical services. Telephone interpreting services will be required. The cost of tested, competent, and ethical interpreters in person ranges from $30 to $60 per hour. Per the APA, it's $45 to $150 an hour in person nationwide. Telephone interpreting is $1.25 to $3 a minute. All of the former often require a 2-hour minimum. Video remote is $1.95 to $3.49 per minute, and that may also have a minimum. The time required for an interpreted session in consecutive mode is double that of a non-interpreted session. So the clinician and interpreter are almost always paid for 2 hours. A monolingual English-speaking clinician can serve half as many non-English speaking people as English-speaking people. But there is another approach to mental health care. The peer specialist has a wisdom gained from 1 to lifelong years of lived experience and skill in providing this approach.
Thank you, Laurel. If you get time is up, if you could please wrap up your comment.
CEO providing peer support with a community-defined evidence practice without the need for interpreters is effective in cost and time. Large numbers of non-English speakers will never be served because
Please wrap up your comment.
of workforce services.
All right, thank you. Susan, your line is open. Please go ahead.
Hello, everybody. My name is Susan Gallagher. I'm the executive director of Cal Voices, the oldest peer-run organization in California. I want to address several things that we're very concerned about, but I want to start kind of wish that Stephanie was still here along with because reasons why we don't trust because they get leave every time there's public comment. Michelle Bass has done that at every meeting with the public, and also that they have not engaged the public directly except through commissions like yourself or some other agency, and that they never respond to our questions. They only respond to the commissioner's questions. So all of those things go along with this lack of trust, and it needs to be really recognized by the administration because there's a form of arrogance there. And so I want to start by saying that, but obviously we've talked a lot about the CSS pot reducing what is now going to be the BHS pot of money by from $1.3 billion to $621 million. And then we're going to use that same shortened pot of money to serve an entirely new population of standalone substance abuse with MAT services, mandated MAT services. So medicated assisted treatment, not recovery-oriented services, not wraparound, not wrap groups and things like that, but medical model services. I'm not saying these medicines aren't good. They've saved people's lives, but not necessarily what MHSA should be funding. Seems to me that our opioid settlement money should be funding that. And what is realignment going to be funding in the future if MHSA is backfilling all of realignment? We have a non-supplantation clause for the mental health dollars with the modernization. We do not have a non-supplantation clause for the Medi-Cal dollars. Okay, well, we would like to also see peer support in CalAIM. We don't see that anywhere in the CalAIM, and we're really, really concerned about that. Thank you very much today.
Thank you, Susan. Rachel, your line is open. Please go ahead.
Hello, my name is Rachel Shear. I am a social worker. I'm also a person with lived experience of substance use and houselessness in my past. And today I'm speaking on behalf of myself. I would like to raise a concern that this financial restructuring, that it potentially is going to fund things like care courts, which have involuntary forced interventions for substance use disorder, and how by funding those, it's the same pot of money. You're taking away services from elsewhere, as has been outlined today. And forced interventions are really not best practice. It's not research-based. And I would like to advocate that there are more people with lived experience brought to the table when discussing what these policies are that are meant to help them. I'm in full support of people with substance use disorder getting as much help and support as they need, and increasing funding for those services. But anything that involves involuntary or forced interventions, it's like throwing money into the void. And you're also then introducing populations of people with substance use disorder who are not interested in cessation into programs where there are people that are interested in recovery. I'm also familiar with trying to get people into some of these services, and there's really long wait lists. So if then people are being prioritized because of forced interventions, that could then leave people that are there voluntarily for services out of getting services. Thank you so much and have a good day.
All right, thank you. Danny, your line is open. Please go ahead.
Hello, can everyone hear me?
Yes, we can.
Perfect. Thank you so much. My name is Danny Therical. I'm the Public Policy Coordinator for the California Youth Empowerment Network. Thank you for allowing me to address the commission and everyone there in the room. I want to be quick about this and echo the sentiments and comments from fellow peers regarding the preservation of PEI, especially as it relates to the LGBT youth and community. Currently, there is a huge anti-LGBTQ movement in our schools. School districts are considering and have already adopted policies that would have school out students, and the services and provided through PEI to local communities and community-based organizations are going to be vital for those youth. I myself, as a LGBT youth in high school, or my high school did not have any of those services that I could reach out to, and had to take a city bus across the city in order to just attend a weekly youth peer night group. So I urge that preservation of PEI. Two more points that I wanted to talk about were the membership of the OAC. The proposal includes adding more members, 2 members of family members of children with a mental health challenge or substance use, or social or SED, and we highly recommend increasing the peer voice and more specifically requesting the addition of 2 TAY representatives on the OAC in order to give a more full perspective of the family environment regarding these issues. And then lastly, it's clear that this proposal creates a drastic change in our system, and that a lot of talk needs to happen regarding coming up with a proposal that we can all at least somewhat jump on board with. And the push to have this on the March election is really crippling that process, and recommend moving that to a November election, where not only will we have more time to discuss these proposal, not only will we have more time to discuss this proposal, but also be able to engage a larger voter base, and specifically our youth population and youth voters. Thank you.
Thanks, Danny. Corey, your line is open. Please go ahead.
Hi, good afternoon, commissioners and panelists. Corey Hashida on behalf of the Steinberg Institute. Thank you for the opportunity to speak today. I'll keep things brief to be respectful of folks' time. We just wanted to comment to indicate our support for this really transformational proposal that the governor and the administration have put out. We really think that this package of proposed changes to not just the MHSA, but really across our behavioral health system, especially in terms of measuring outcomes and bringing more spending transparency into the system, together bring the MHSA and the system as a whole into alignment with what the original vision for the MHSA was, building off of pioneering pieces of legislation in AB 34 and AB 2034 authored by our founder, which led to comprehensive and wraparound care for our most vulnerable. Again, just wanted to indicate our support, and thanks again for the opportunity to provide comment.
All right, thank you, Corey. Dana, your line is open. Please go ahead.
Good afternoon. My name is Donna Paikau on behalf of the National Center for Youth Law. Thank you for the opportunity to provide public comment today. We share the administration's goals to address homelessness. However, we also share and want to uplift the concerns expressed by others today that the proposal would divert funds from prevention and early intervention. As we've heard today, this will be harmful for youth who currently rely on MHSA-funded programs and services. And we appreciate that the SB 326 now includes a set aside for upstream prevention and language that directs counties to prioritize early intervention services for youth. However, this alone is insufficient and does not meet the current funding levels for children. We respectfully request that considerations be made to maintain current funding levels for prevention and early intervention programs for children and youth, along with ensuring that a proportion of those served in FSPs and their housing interventions are young people and families. Investing in the health of our children is critical to ensuring they become thriving adults. Thank you for your time.
Thank you, Donna. Nora, your line is open. Please go ahead.
Thank you. Nora Lynn on behalf of Children Now, who respectfully opposes SB 326 unless it's amended. Children Now is thankful for the investments being made by the legislature and administration in children's mental health, and are especially thankful to the Commission for the work you've done to support children and youth over the years. We are, however, deeply concerned about the impact of 326 on children and youth. The MHSA has worked to fill in critical funding gaps where the state has underinvested and is a critical resource to the continuum of mental health support for children and youth. While we agree that the MHSA should be updated, we are troubled by the state's short-sighted strategy in rerouting key investments away from children. We are recommending the legislature set aside funds for children and youth in every category of MHSA funding, and we hope the Commission can take a similar stance. Thank you.
Thank you. Madam Chair, that was the final public comment.
Thank you so much, Lester. I want to thank everybody who made public comment. Thank you for staying along through this process. It's been a while now. So thank you for hanging in there with us and making those comments. I also very much want to thank our panelists. You have been here for a while, and we greatly appreciate that. I don't know how many more kind to bars we can hand out or how much soda and water and coffee we can offer. But most importantly, we are very grateful as a commission. I know I speak for all my commissioners here. I would respectfully ask that you stay in contact with our staff so we can continue to communicate and work forward together and continue to inform the administration. So if we could do that, please stay in contact with us and let's just have that united front. I think we want to get this right. And so we need everybody's voices here. So please, thank you so much for being here. We appreciate it. Have a wonderful day. With that, we are going to take a 30-minute break. So 30-minute late lunch break. We will return back at 2 p.m. So we'll see you then. Welcome back, everyone. Thank you for everybody's patience. We are doing our best to catch up. So we're going to move on to agenda item number 8. The commission will hear a presentation on best practices for community engagement to support commission projects and elevate the voice of marginalized communities. Community engagement is fundamental to our work. We as commissioners represent diverse communities in behavioral health. We have educators, providers, employers, law enforcement, family members, and consumers who sit on this commission. Engaging the public informs our grant-making, policy work, and drives supports for all of our efforts. While the commission invests a tremendous amount in community engagement, we also recognize there is always opportunity for continuous quality improvement. As we begin to think about our new strategic plan and moving forward in these changing times, we want to deploy best practices in community engagement to make sure our work will have the greatest impact on the communities we represent. Today, we will hear from Dr. Sergio Aguilar Gaxiola, who is the director of UC Davis's Center for Reducing Health Disparities. Dr. Gaxiola is the co-author on a series of national best practice guides reflecting the state of the art of effective engagement. He has extensive experience in working with the underserved and marginalized populations, focusing his efforts on determining unmet mental health needs. We hope to use the information we hear today to begin to consider how the Commission can design a framework for community engagement that is best in class. Dr. Sergio Gaxiola, I hand it off to you, sir. Thank you for being here, and please, thank you for your patience.
Well, thank you so much for that kind introduction. And I'm very pleased to be here and also honored and appreciate this opportunity to share with this important, very important body that I have known since it began, back in 2005, to speak about a topic that I'm very passionate about. And in our center, we're very committed to, a question that is how to advance health equity and mental health equity with historically underserved populations through community-based approaches. So community engagement is absolutely a part of what we do, and we have been doing since we started with the center and previously as well. If I can have the slides, that would be great. Oh, super. So let me see if I can. So the title is Why Meaningful Community Engagement Matters, and best practices about community engagement. And the bottom line, actually, I decided to put it right in front, is because I'm sure that all of us have the common goal of improving the health and mental health of all our communities. And that is through reducing health disparities, because the disparities are so present and so difficult to change that it is important to have that idea about that one of the, for me, the North Star of this is to advance health equity. Okay? So one key element is community engagement, just right from the go. And one thing that I wanted to emphasize related to that is this thought that is included in the National Academy of Medicine, which for over 4 years we have been working on assessing meaningful community engagement measures in health and healthcare at the national level. And this comes from one of the slides of the National Academy of Medicine. And that is authentic and sustainable community engagement is integral to advancing health equity and eradicating barriers to community well-being. And I'm hoping to provide you with some information related to that. But what I would like to first is to share with you the latest definition of community engagement, which is the best that I have seen. And, the CDC, they released back in 1997 a booklet that is called Principles of Community Engagement. And right now we are on the 3rd edition, as I will share with you. But the same definition held on the 2nd edition as well. So this is totally a different, an updated definition on what we have learned through the decades about what, how to better capture what community engagement is. And there are many definitions, but this one says community engagement is an ongoing, evolving process of multi-directional communication. This is very important, with and for people to solve the problems and address the concerns that matter to them. This is another important thing. The process should be durable, long-lasting, and equitable to all who participate. The ultimate goal is to learn, implement, and disseminate the practices of equitable partnering, influence policies, programs, and practices for the betterment of the community. But right from the go, when we included, I was a part of this chapter that you see here, when we said multi-directional communication is to capture the need to listen to the communities. All of us who are working towards reducing mental health disparities or advancing mental health equity have to realize the importance of listening to what matters to the communities. So I want to share with you that community engagement has become a hot topic. We have been following this for quite some time. And what you have in your, by the way, I know that you have it in your handouts, the slides, as well as 4 pieces of information that I go along with what I'm presenting to you. But this has become a hot topic, especially during the pandemic and right after the pandemic. There are so many lessons that we have learned of what happens when we don't engage the communities appropriately, especially those who disproportionately were negatively impacted with higher mortality, for example, here in California, as we saw it. Some populations dying in disproportionately compared to other populations. And it was to a great extent because there was no meaningful engagement of those communities in going to where they were, okay? And I'll speak more about that. 2 of those pieces that you see there are from California. One on workforce and the other one is, working with community-based organizations. Coming to the Mental Health Services Act, I have a quote on top that comes directly from the statute, MHSA statute, and you see the page number there, that tells you, a little bit about the importance of increasing the number of PEI programs and systems, including those utilizing community-defined practices to focus on reducing disparities for the communities that are, negatively impacted and have been for decades. This is nothing new. And then part of what I have been looking at the implementation of the Mental Health Services Act, including what you do, the 2 components that you oversee, PEI and innovation, that it required a community planning process. This is very, very important, and we need to get it right because, as I will share with you later, we need to ask who benefits from all of this? Who are the primary beneficiaries of what we are doing. So community-driven initiative and service delivery design, and this is co-designed with communities that stand to benefit to reach traditionally underserved populations. So I'm going to speak, I'm going to highlight three best practices on community engagement, share with you, and I won't stay too much in each of them because my message is different. I want to come to sharing recommendations with you. So one is this, what we call ICCTN model and learning collaborative. And another one is the principles of community engagement, the third edition that is about to be released, after working in it for a couple of years. I'm very much involved with that one as well. And another one that is very, very close to my heart is the National Academy of Medicine, Assessing Meaningful Community Engagement in Health and Healthcare. And I have been the co-chair of this initiative for over 4 years now. So let me get started with the first best practice. And that is, the long name is, as you can see on the screens, Interdisciplinary Collaboration and Cultural Transformation Model. This is a long, name. Sometimes I have to stop and think, what does ICCTN mean? But this is the name that the communities themselves decided to call it. And we absolutely went along with that. And the other thing is that this was funded by you, by the Oversight and Accountability Commission through an innovation project to Solano County. Okay? And then Solano County, and I'll tell you a little bit more about that, they asked us when at that time, that was in 2014 or so, the then director of the Behavioral Health Division came along with 3 of his leaders to talk with us to see if we could help them, focus on the 3 populations that you can see in the map there, Latinos, Filipinos, and LGBTQ. And what we did, and there is not enough time to give you details, is that we anchored this work on the nationally recognized culturally and linguistically appropriate services standards, CLAS. I don't know if I can have a sense of how many of you are familiar with CLAS. Okay, all right, very good, excellent. And we have been working on the CLAS standards, created a toolkit curriculum starting in 2006. And it took us 5 years to do that. And we have been using this toolkit curriculum that we call Providing Quality Healthcare with CLAS. And CLAS refers, of course, to the standards. And this is also, as far as I know or we know, the first project that combines the CLAS with community engagement. And so very quickly, so you see what the baseline, when Haley Simmons and his leaders came to meet with us, they said, there is, for years, there has been these inequities in access to care, in the use of services in Solano County. And he provided us with this information that you see there. And you can see at the bottom of that slide, both Latinos and Asian and Pacific Islanders, which means in Solano County, Filipinos, 76% at that time of the Asian and Pacific Islanders were Filipinos. And I understand that is the largest concentration of Filipinos in the state and maybe in the country as well. Didn't know that when we started working in Solano County. But you see, Latinos and Filipinos were, at the bottom of penetration rates. This doesn't include LGBTQ populations because at that time the county was not collecting data, if, let's say, on sexual orientation and gender identity, and we help with that. And now they are collecting data. Now we have data, as I will share with you. So they were very concerned about this, and the county had been working for 3 years on what they call a cultural competence committee to try to change the data that you see there. And unfortunately, they were not able to do that. But they did a lot of inroads that we consider, and we built upon those, the progress that they had made at that time. So Haley Simmons and the other leaders, they said, oh, that's great. You are willing to play ball with us. Can you give us an idea as to how you are going to go about doing that? And we came up with this very simple model that is comprised of 3 different phases. The first phase is a comprehensive health assessment that we went and listened to the 3 populations that they asked us to focus on. You know, we look at not only listen about their needs, their experiences using the mental health services, but also we went after their strengths, their assets, and their resilience. Because we tend to neglect that when we listen to people, especially with mental health issues. So we collected information through several means, actually. It was key informant interviews. We did a bunch of those. We did focus groups. We did community forums. And the information that we collected actually was very much related to the second phase, which was it was the intervention. But what we did was to train not only county employees and also community representatives, but representatives from various sectors, social services, churches, faith-based, law enforcement, transportation, because these populations, when they don't use the mental health services, they go somewhere. You know, the needs are there, but they just don't use the mental health services. So we needed to get them involved. And we ended up training 3 cohorts, about 50 some people representing the various sectors at that time. So the second phase was to train them. And what we were expecting them to do was to come up in small groups with action plans that we call quality improvement plans, okay? And the third phase was the implementation, and continues to be the implementation of the action plans or the quality improvement plans. So these are the community-based organizations that we work with. You know, Solano Pride, LGBTQ focused CBO based in Fairfield. Fighting Back, focused on Filipinos in Vallejo. And Rio Vista Care, focused on Latinos in Rio Vista. And so what are the outcomes? There is a lot of stuff that I just don't have the time to share with you. But very quickly, what are some of the outcomes? And what you have there is just a couple of outcomes. There are many other outcomes that are described in great detail in one of your handouts, which is the ICCTM model final evaluation, that if you are interested in improving or advancing mental health equity, you will find details there, okay? So these are the 2 outcomes that I want to bring to your attention. In your right-hand side, is that there was a significant increase in calls to the access line. And overall, it increased by 29% during the life of the project. But look at that, in the LGBTQ, it increased over 300%. And with Filipinos, it increased, as you can see in this, 32%, and with Latinos, 41%. On the left-hand side, this is improvement in intake assessment offered within 10 days. Because one of the big issues is that when people finally get into the doors of service, sometimes the services are offered 2 months or 1 month. So the county was striving to reduce the intake time within 10 days. And you see the improvements in the 3 different populations that I'm showing there. The other outcome that is very, very important for the county, I have heard many times that this was really, really important, and that is there was a decrease in first admission via crisis services by the percentages that you see there in the 3 populations of focus. So people started to get into services with outpatient services and the reduction on crisis services. Crisis services are very expensive, and they tend not to be that, because of the long-term treatment, it is, may not be as effective as we would like them to be. But one thing that I want to emphasize is that these trends, according to the county, reflected increased trust towards primary mental health care providers in Solano County and resulted in substantial cost savings. We had, among the group of evaluators, we had a health economist to really help us, look at the cost benefit. And many details, once again, are included in the evaluation report that you have in your handouts. This is the report that you have now. And this, we provided evidence that it is possible to advance health equity in these historically underserved populations. And it was the commission, we had presented before to you, saying this is what we found. And there was a lot of support on creating what we call a learning collaborative, and that is to really train as many representatives from as many counties as possible. And we had been training for almost a year representatives of 44 counties on what we call the learning collaborative. And what you have there is 11 sessions. We are right now on the 10th session. But one thing that we did deliberately was to include 3 sessions focused on community engagement, because when we did the exit interviews with the leadership in Solano County, they coincided that one of the most valuable interventions that we did was community engagement. And there are so many stories that I would like to share with you, no time to do that. But we saw, actually, through bringing together, the county with the CBOs, with the community to talk like what we are doing here, and the changes that happen. Building trust was incredibly important. So 3 of the sessions, once again, are focused on community engagement. And we are, this coming week, we are doing the first of 2 cohorts, training on precisely on measures on community engagement, and also the importance of trust and trustworthiness, as we did on the 9th session. These are some of the lessons learned that I want to share with you. This is an accumulation of, of what I have learned over the decades, actually, doing this kind of work. And some like multi-stakeholder community partnerships are needed, are required, like with the Modernization Act that I heard so much this morning, and I'm glad that I came specifically for that. A strong message was, we need to engage the communities, and to listen to them and see what matters to them. So the other one is use a healthy equity lens. For me, one of my North Stars is health equity and mental health equity as well. It's so important to have a clear idea about this. The other thing is, the point that I have been doing is listen attentively to all and treat partners with dignity and respect. Review local data on mental health outcomes in local communities and connect the dots to look at the patterns that connect, and look for what is missing. Where are the gaps in the data? Actively look for community assets, strengths, and resilience, and use them, is the point that I just made a few minutes ago. Also, design and implement for sustainability right from the go. The other thing is start. Don't overplan. Learn and adapt as you go. This is one of the cases of flying the plane as we build it. But the one that I really want to emphasize with all of you, and I cannot emphasize it enough, is the critical importance of building trust and becoming a trustworthy organization that are front and center. So to simplify, I'm going to use the 4 S's, as I call it, as we go and engage with communities. 4 S's, to be sincere, to be simple, to be straightforward, and to shut up. And listen. It is so critically important that we learn to do that and value the input, once again, of the populations that we work with. So one key question is, how do you do meaningful community engaged work? Well, an answer that has been around since 1997 is to follow the principles of community engagement. This second edition that I was very much involved with, I was the co-chair for these 2 versions, English and Spanish, has been downloaded from the CDC website 10 million times. 10 million times. It has been downloaded, the English version, in 170 English-speaking countries, and the Spanish version in 63 Spanish-speaking countries. So it is widely used. And we anticipate that the 3rd edition, my hope is that put it in the water, because there is a reason why people are downloading, and this is for free. All of this is for free, by the way. One thing that I want to emphasize is that since the 1st and 2nd edition, there were traditionally 9 principles that were included. Principles like build trust and relationships and get commitment from formal and informal leadership. But in the 3rd edition, that once again, we are waiting actually for the forward, and we're hoping that the DHHS Secretary of Health is going to provide us with the forward for the book that is already done. So we included a 10th principle. And the principle is about trustworthiness, which has emerged with such a force that we need to realize that if we are to be effective as we engage with communities, we need to become a trustworthy organization. What does that mean? Well, there are some pointers here. Trustworthiness is essential to forming effective partnerships, and over time will deepen commitment through building relationships based on empathy, honesty, respect, and humility. Partnerships built around the liberty means of engagement and bidirectional, I would say multi-directional communication are required. And then to listen attentively to what matters to communities is absolutely necessary, okay? Now the third best practice, and this is, once again, the National Academy of Medicine that we have been working for over 4 years. This is being done by an organizing committee of 34 people. It's really experts at the national level, 13 of which are community members. Actually, it has taken us 4 years because of that. When we decided to include community members, it really changed change what we were doing, and I'm so glad that we were able to do. So what you have here is the conceptual model that once again, you have it actually. I included an article that I would encourage you to do it. And this conceptual model, even though it looks complex, and this is the outcome of over 20 conceptual models, community engagement conceptual models, that we studied in depth. And this is the best that we came up with. And what I want to bring to your attention is that there are these, some people call it pedals or propellers, is this sense of dynamism. And there are 4 propellers or 4 pedals, but what is front and center is community engagement, the importance of focusing on community engagement. And what this is the simple message that I want to give you with this complicated conceptual model. The connection and interrelation between community engagement and health equity or mental health equity and transforming systems of care. What I want to bring to your attention also is the pedals that you see there is a strengthen partnerships and alliances with many elements, expanded knowledge with some elements or indicators, improve healthcare programs and policies with some elements, and then thriving communities with some elements there as well. So if a lot of people are looking at this as a roadmap. If you ask, how do we go about advancing mental health equity? Well, this is a roadmap that can help you, and not only help you, but the indicators that you see within each of the pedals, it has a measure. We did a very comprehensive review, and we, after looking at over 1,500 articles that we were able to find, we end up with 28 measures that were released in the middle of May, freshly released, along with 7 impact stories as well. So I included a handout for you with the links that if you are interested, you can look at this in more detail if you wish. But one thing that I want to bring to your attention is that surrounding community engagement are principles, and one of them is trust. And I so much want to emphasize trust. And in the article that I included is information about what I'm including here in this slide. Trust is a core component of engagement or community engagement. And it requires showing up authentically, being honest, following through on commitments, and committing to transparency in order to build a long-lasting and robust relationship. Change on the part of all partners. We have to be willing to change ourselves as we engage meaningfully with communities. The entities engaging communities commit themselves to being trustworthy. And then a foundational component of building trust with communities is demonstrating that community trust is warranted and will not be abused or exploited. That is very, very, very important. I have made many errors in my life, but hopefully I'm learning, on how to adhere to these principles as we do work with communities. Just a few more slides, and then I'm going to stop. And this is just to emphasize that we need new models of service delivery, because as my first bullet says, that health and mental health inequities for especially historically underserved populations, and that includes immigrants, which is a population that we have been working, have persisted for decades. Actually, I think, and there is some indicators that these inequities after COVID have been even more pronounced. There is national data, there is state data, and there is also local data to accompany this. The inequities, as I mentioned, have been particularly exacerbated during COVID, and the new models are much needed to effectively increase access to care and utilization of services, especially where people live, work, and congregate. So we go to them as opposed to waiting for them to come to us. And there is a good reason why we ought to do that. This is, I don't know how many of you have it in your radar, what has been called the ecology of medical care. And this is something that was introduced here in the US in the 60s, 61 to be precise. And there has been a revisited, and there has been revised again. And basically, even though this looks complicated, what it says is that out of 1,000 people on the streets, 1,000 people, 800 are going to report symptoms. Some of them are going to be mental health symptoms. About 327 would consider seeking medical care. And then you see, the trickle down all the way to 200 visit a physician's office, 21 visit the hospital outpatient clinic, and 8 are hospitalized. And less what? Our medical center at UC Davis gets less than 1 out of 1,000 people. And there are tremendous differences also by race and ethnicity here. So this is kind of the overall. So what I want to emphasize here is that the prevailing model of healthcare service delivery has been what I call the waiting mode. It is, come to us, okay? But look at this, many people are left with unmet health needs and mental health needs as well. So we need to change. There is a paradigm shift that needs to happen, and my hope is that you would consider this. Maybe some of you already have these ideas. A paradigm shift from the waiting mode, in which, once again, it is waiting for those in need to come for services. And, in this is treat conditions when the symptoms are set, complications ensue, and normal function is lost. This is too far away, So the other alternative is the seeking mode, that we need to go to them where they are, in which we intervene before the symptoms appear or when they start and preserve normal function for as long as possible. This is where prevention and early intervention plays out. And so just to give you a sense, I did a study along with many of my colleagues in the 90s. It was in Fresno County. At that time, I was living in Fresno County. And these are some of the institutional barriers for those people that we identified that needed services because they met one or more mental disorders, criteria for mental disorders. And this is what they said. Over 50%, they didn't know where to go. That's amazing. 50%, I have no way to pay. 1 out of 4, there are no treatment centers near my home. 1 out of 5, I can go to the clinic during open hours. And 1 out of 5, I can go as frequently as needed. So you see there the barriers that we have known for decades, actually. This is nothing new. So what is it that we can do about it? Well, this is what I'm hoping to invite you to reflect along with me is what is the road or the roads ahead for you, okay? And for us as well, is what are the outcomes that matter? Well, some questions that I'm gonna ask is matter to whom? Who defines the outcomes? Who benefits? There are gonna be wrong turns, as always happens. And then how do we know when we get there? This has to be outcome driven. And then this is in the middle of the road. This is really in front of us, is to serve the underserved communities on what matters to them. So this was a prelude to share with you some of the recommendations. These are very bold. I'm sorry if I'm this bold, but for the first one is put community engagement in the water of what the Oversight and Accountability Commission does in collaboration with your partners. It will necessitate an organizational cultural change. For example, include community engagement in the OSC strategic planning process, which I understand that you are getting into that, or maybe you are already in it. Be guided by community engagement best practices. Second recommendation, take the lead and become a model agency on community engagement and advocate that every state agency should have an established community engagement plan as part of the strategic plan. I understand that all of the state agencies are required to have a strategic plan. I don't know if they are required to have a community engagement plan, but I think that you, as a body, can really get ahead of, be leaders at the state level on incorporating something as needed as it is community engagement, because I know that you are focusing on that advancing mental health equity as well. Another one is if there is not, a community engagement in the agencies, well, consider sponsoring legislation to fortify community engagement across all the state agencies. Consider that. Advocate for the state to fund community engagement at a level on par with the disparities that need to be addressed, because they are hand in hand. They happen together. Advocate for the inclusion of meaningful community engagement in the Modernization Act. Boy, I heard, I had an earful throughout this morning, and I think that the feedback that we got really is on target. And we need to consider that it's better to go to get it right than to get it fast. Okay? Perhaps we need to put the brake a little bit and have something that is much more thoughtful. Then two more recommendations. Provide training on community engagement best practices to various stakeholders and how to successfully do community engagement with accountability. This is looking at, this is outcome-driven and impact-driven as well. We know how to do that. We did it in Solano County, and we have done it in other programs as well. And the last one is a little bit self-serving. I'm sorry, but I needed to take this opportunity to continue to support the statewide learning collaborative training counties, because we are on the 10th session about to get, and we are hearing from the counties that they want a 2.0, because we have been building trust throughout the year, and they are ready to really do something else. And one of the beauties that I have seen, along with my colleagues, is that they are talking with each other. They are changing resources. They are really advocating for this work, something that tends to be silos. I'm sure that this is not going to come as a surprise to you. So that's it. Once again, thank you so much for the opportunity to share some of these thoughts and some of the best practices with you.
Thank you, Dr. Gaxiola. I think that I would want to ask if any of my fellow commissioners have questions or comments. I want to thank you. I know you've waited a long time to be here. I appreciate the information. And yes, you saw today how community engagement, how important it is to members of our community. And I think how we take it very seriously, and we want to make sure that it is informing policies and practices around mental health in our state. I'd like to make a comment. There's a lot of, I appreciate the recommendations. Thank you for making that easy by just putting them out there for us. So I appreciate that. I do agree that it needs to be, there's kind of an ebb and flow when it comes to community engagement. Like you said, it's a hot topic. I think after the pandemic, everybody started, community engagement. But for the longstanding our community, it wasn't a hot topic. It was just constantly there. It's always ever present. And so the investments we have and the work that you've been doing, thank you for that, because it's important that it's a staple of everything that we do. And in one of the things that you mentioned here, the lessons learned, I appreciate all those points, and I really like where you talk about reviewing local data and reviewing it with the community, because it's their information. It's not ours, it's theirs. So really having informed conversations about data that is representing of the community, and then building together the resources, the programmings that's relevant to them. I think that's important. And when we push off that community engagement, it's almost like, it goes to the trust. We want that conversation, right? So that's when we start to hear about not having trust, when we avoid those conversations. So it's so important, especially when we're looking at information and data. So I really appreciated those points, and I thank you for everything that you're sharing. We want to look more into this, and I think the more we can continue these conversations and just promote everything that you've learned thus far, and continue to share it with our counties, I think is going to be really important. So I appreciate your time here, and we'll absolutely dive into this more.
Yeah, thank you so much.
Thank you.
Yeah, appreciate
Thank
your
you.
comments.
Commissioner Templin, did you want to make a comment?
Thank you, Chair Madrigal-Weiss. I want to echo the appreciation, Dr. Aguilar. Osceola.
Yes.
Did I say your
Yes, you said it right.
Okay, good. I always want to make sure I pronounce it correctly. This is dear to all our hearts, right? And you've brought now the research and the work that you've done to be another, and more resources to guide our continued efforts to this. And I really appreciate the recommendations. I support them, especially at the level of, you've talked about the Modernization Act, the care court process. At the state level, there's a lot of learning from what our communities are doing locally on this kind of, engagement and building trust and, and asking the right questions to get, working together to get to the definitions that we're around outcomes. And so I really just appreciate all this. I'm curious how you guys handled, or what you did around the incentives for the folks, meet them where they're at for sure, but also, because in Alameda County, we have an ongoing community engagement program through the Office of Peer Support Services, and the peers define the name of the program, Peers Organizing for Community Change, yes. And the POCC, and 1,600 peers in our county are involved in it on a monthly basis. Around 80 at least get a stipend for their ongoing involvement in the committees that are specific to their culture and ethnicity and age group and gender identity, also sexuality. It's very robust. And so I always love when we engage about our community, and what they've told us is also we are coming, how do we make sure that engagement also, when it's consistent and it's is funded in a way that they're getting recognized for their wisdom and their contributions to our process. Have you got anything out of that?
Yes, no, it's a great question, and thank you for your kind comments as well. It's great to see you again. Chi and I chaired, the membership at the National Advisory Council of SAMHSA, the Center for Mental Health Services. And it's a great question, and let me share with you what we have learned, okay? Because during the pandemic, we got several funded projects to do COVID-related, okay? To provide free testing, for example, with mobile units that we went to where people were, and also to do vaccinations, testing and vaccinations. And to those who were positive, right on the spot, provide telehealth services and telemental health services on the spot. So in a matter of minutes, those who were in need of treatment, they were speaking with the primary care doc who provided, whatever treatment was needed. And we even, really tried to provide the medications. For example, in the test to treat, that was a test to treat the CDPH funded. And we would, try to get them the medication as well. And this was in very close collaboration with fairly qualified health centers. Okay, here in Sacramento, for example, with WellSpace, which is the largest, by far, the largest FQ in Sacramento, 150,000 patients that they have, 31 clinics, which, by the way, 9 of them are behavioral health clinics. And they are, everywhere throughout, not only Sacramento County, but, Amador County and Placer County as well. And in the Sacramento Valley, with Ampla Health, 4 different counties. They are covering 6 counties, and this is Butte, Sutter, Tehama, Glenn counties, very rural. And what we learned as we went talking about incentives, we went to offer the services. We learned very quickly that we needed to be constant. In order to develop trustworthiness, we needed to show up. And I saw personally how, building trust played a key role, like going to migrant centers, for example, here in Yolo County, in Dixon, Madison, Davis campus, that we would go, and very few people would come at the beginning. And fast forward, months after going weekly to where they were, and showed up and showed them that we were trying to be trustworthy. To see a mother coming with that 6-month-old baby, and say, test him for COVID because we got COVID in the family. You don't do that if you don't trust. And that's, what are the incentives? Right now, actually, we're expanding that to do preventive health screenings, including mental health screenings. For example, depression and anxiety, and also blood pressure, and we are considering glycemia as well. But we will go where people are, and we will show up consistently in some of the places so they get to know us, and they get to see that we are not there just one and done. Have to develop trust with the communities. And what would be the incentive? Well, as we saw it with the testing that we did, and we absolutely think that we were able to save some lives because some of these folks were not vaccinated. They even didn't know that they could get vaccines free of charge, for example, many of them. And the disparities, were tremendous. I saw it. I was asked by the governor's office to be a part of the this task force right before the vaccines that was called the COVID-19 Priority Guidelines. Okay, and we got together, 14 of us, looking at the data, and we were seeing data that I haven't seen before of who was dying out of the essential worker sectors. And guess what? Those who were dying left and right of all the 15 essential worker sectors were agriculture and food, followed by construction and manufacturing. And it is because of the disparities that happen, that these populations.
They also look like a certain person,
Yeah.
right? They look like me. So
Yeah.
it's
Absolutely.
not just the industry, it's yeah.
Yeah, no, you are absolutely right. So there are intrinsic incentives. We happen to get resources to provide gift cards, for example. And we would ask, always trying to listen to what the needs were, what mattered to them. So we had gift cards, Walmart, Target, whatever store they purchase, and we had many choices. But those are only two of the incentives. We created several other incentives and wish to speak with you more, but it's a wonderful, wonderful. And this is a question that we continue to ask ourselves as we go out to where people are with the preventive health screenings, what's going to bring them to us?
Thank you for sharing that additional extra detail of what you did when going out, because that really, I think, paints that picture of what we need to do more of and support more of across our whole state, because it's no longer you come to us, it's how do we come to you so we meet you where you're at. Really walking the talk of meet you where you're at.
Absolutely. It is that paradigm shift because, shift happens. It is not my line. It is our chancellor's line at UC Davis that I heard him say that. I said, can I use it? And I said, sure. But I want to give him credit. Yes, yeah.
Commissioner Rolette, I saw your hand earlier, and I don't know. I don't want to put you on the spot, sir. I'm just asking.
Certainly, my comments will be brief. First, Dr. Galaxiola, Sergio, hello. How
Yes.
are you? It has been a long time. And it is always, commissioners, great to see such a distinguished leader in this area. I go back to the slides that had the main lessons learned, the 4 S's.
Yes.
And I, again, underscore the straightforwardness of that approach, in which straightforward was one of the key lessons learned, and shut up and listen. And I always am hearkened to this notion, and I'll cite one bit of data about Sacramento County. At a recent homeless count, they determined that 30% of the people that are homeless look like me, and people that look like me represent 10% of the population. Why is that disparity continuing to happen? Well, oftentimes the people who are homeless say that there's a lack of sincere appreciation and approach to providing the provision of service. And all of these 4 features, in my opinion, are inculcated in what is successful. And oftentimes it is those ambassadors in that community. And Sergio, I'm saying what you said, that make the difference. So thank you for saying it. And thank you for the endorsing the importance of having a workforce that's diverse to do this work.
Thank you so much. So great to see you again, Alvin. I appreciate those comments and looking forward to in the near future, see you again. You have been doing great job, great work, for decades now. And so I didn't know that you were a part of the commission, so it's very pleasantly surprised.
Thank you very much for that. I hope the commission feels as enthusiastic about me as I feel about them. So thanks for that.
Absolutely, Commissioner Rolette. At this time, members of the public may request to make a public comment on agenda item 8 by clicking the raise hand button on your computer or the app, or if calling in by phone, push star 9. Once the public comment period for this agenda item starts, we will close the public comment queue, so please make your request to comment now. Are there any public comments? Please raise your hand now, as the queue will be closing now. It looks like we have 2 public comments, and the queue is now closed. Lester, if you could please invite our first comment.
Yes, Jerry, your line is open. You may go ahead.
Okay, great. Thank you so much. Thank you, Doctor. I really appreciate your presentation. I've been championing the CPP down here in San Diego for about 8 or 9 years, and it's been somewhat of a struggle. What I guess my biggest concerns are that the CPP is a legislated funded mechanism in every county, and it has some requirements, and one of them is that the advisory boards, which are appointed by the governing body, are approve the processes of in the plan for the next year, presumably, of what the county will do to deploy their CPP. So the CPP, from what I understand, is the process, not it's the mechanism or the vehicle that is supposed to be used by the county to engage the community. And I think one of the biggest problems is that there's no enforcement mechanism. So counties largely do their engagement work. Some do great engagement work, some do a little, some do a lot, but it's not documented. And then when you put it in the financial report, it's not itemized. So we don't know how much money is being spent. It's often blended or conflated with the administrative costs. So I think that we would be light years ahead of where we are right now if we had a functioning CPP where the advisory boards were meaningfully engaged, that the community were being trained at conferences and training sessions, and not just at a forum 15 minutes before the forum, but throughout the year, so that we can grow subject matter experts that can come and give the advisory boards better feedback, so we can give better feedback to the supervisors. So my concern is that a lot of when I hear community engagement, I hear blah, 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 because it's not to be offensive. And I think if anybody is offended by somebody criticizing the CPP process, think about why you're offended. This is not an attack against you or your body, your county, your agency. This is a perplexing question. Why do we have this mechanism sitting there that nobody's willing to enforce and to utilize? So I think there's a beautiful tool sitting there. I would love to see it deployed. If MHSOAC is using this for their own projects and plans, I think it'd be great if you created your own CPP plan and built a team of stakeholders that could give you advice that you may not formulate yourselves or hear on your own. The whole idea here is you're trying to get the consumer community involved in their mental health system. And I feel like
Your time is up. Please wrap up your comment.
I'll leave it at that. Thank you so much.
Jerry, I so much appreciate your comments, not only this one that you just made, but the previous one, that I heard you clear and sound, and what you said earlier during the Modernization Act discussion, what you said very much resonated with me as well. And I happen to believe, strongly actually, that the uniqueness of the Mental Health Services Oversight and Accountability Commission, you, and the leadership role that you can play. There is no other commission in California related to as you have by statute, and I think that the community, you are a community, you're representing several members of the various communities. You come together with your own, uniqueness, and I truly think that you are in a position right now to be the state leaders on something like community engagement. You can make it happen, and the other agencies can learn from what you can do. I truly believe that you are in that position.
I would say many of us would agree with that statement. We are going to continue on with our, we have additional community members who would like to speak. So please, Lester.
Yes. Richard, your line is open. Please go ahead.
Good afternoon. Thank you for your very insightful presentation. I truly believe and support what you've been saying, and I hope that the commission will take those additional necessary steps to make it more inclusive. But what bothers me the most which I agree totally with Jerry, what he said about the county level with the community planning process. It's not done the way it should have been done. There are behavioral health directors that do not have the buy-in with the community planning process. They're doing it with their mentality, my way or the highway, the old way before the Mental Health Services Act was created. They don't want consumer families feedback. That's part of the problem with our counties not making a transformative change within the counties to improve our mental health system along with the Oversight Commission. So they needed a lot more training from you that you can charge them big bucks to make them listen to you of what they need to do that benefits the entire mental health community across the board. This has been one of my frustrations as a volunteer for the last 5 years. As a state ambassador with Access California, I've been vocal with the Oversight Commission. It doesn't seem like they have an open door policy. So that's just my statement and my feedback. Thank you.
A very important statement. Thank you so much for sharing that, and your experience is very valuable.
Thank you, Richard.
Thank you. Susan, your line is open. Please go ahead.
Sorry.
Thank you so much. Sergio, it's been wonderful to hear from you today, and I appreciate everything that you shared and wholeheartedly agree that, MHSA really put community at the forefront of everything we did in the behavioral health system. And we want to see that continue, even though it has not been perfect in a lot of places. We would like to see that modernization. If we have to accept modernization, if we get something like this institute, that it has to be a shared community process and a shared decision-making process, and that we get some language around that in the statute so that we can all feel a little bit more trusting about what we are having to accept here, because it seems like the freight train has left the station. So thank you so much, and appreciate everybody's commitment to this issue.
Thank you, actually, wonderful.
Thank you, Susan. So at this time, I'm gonna, if we could have the recommendations back on the screen. Thank you. Commissioners, if you see those recommendations, there are things that we're already working on regarding community engagement. And I would just ask if you would, I'd like to ask staff to further explore these recommendations, and just want to get your thoughts on that as far as really being more intentional with our pursuing some of these recommendations.
Madam Chair, I wholeheartedly support that. I think that idea and engaging our staff to pursue those recommendations and work with Dr. Jasiola and from these and come back to us would be great.
Perfect, thank you. Any other comments about these?
Just a thought that it would be interesting from a data viewpoint to see if there is any data about the ROI of these programs, in a community versus out of a community, or if there's any data work that we can do on our side to further support this as sort of a subsegment of PEI.
Absolutely.
Yeah.
Thank you, Commissioner. Yes. So we will do that. So Toby, you will loop back with us? All right. Dr. Aguilar Gaxiola, thank you so much for being here. We appreciate your time, and I did not mean to cut you off, sir. It's just to keep this going and
absolutely
to get our commissioners out there. We have postponed 2 items on the agenda, and just for the sake of time, the discussion on universal mental health screenings and the 23-24 spending plan. We will make up for those in our next meeting. Thank you so much for being here. This meeting is adjourned. We will see you next month here in Sacramento. Have a wonderful day. Stay safe.